And today we are here definitely to listen. We are here not only to listen, colleagues, but to learn. This is not new to you. As the program director have said, this has been happening. This year is the 12th year. And we are going to make history. We are going to have the 1,000 conferences to come. So this is not the end. So we are here to listen. We are here to learn. We are here as well to debate, but also to reflect of what we have been implementing, because we have been doing a lot. And also, we are here after this to be able to implement the recommendations of this conference. But also we are here to provide you with the progress of maternal, child health and nutrition annual performance report and the provincial saving mother report. As midwives, you know the saving mothers report again, the content, and everywhere else we are expected to talk about the saving mother report and the implementation thereof. And at one stage we were called in the legislature, Mema Rose was there, to report about the implementation and the progress of the implementation of the saving mother report as Gauteng Department of Health. So we are here to talk about that report as well, but we will be as well conducting the panel of specialists of yourselves and to talk about the maternal, the child. Let us not forget about the child health and all the health care disparities in the maternal and child health, but also to share the strategies to address the primary obstetric causes of the perinatal maternal death at all levels of care. Because everywhere else when we talk about the child and the maternal care. Always they are saying, why are we not performing? Always they are saying we need to give the reasons why we are not performing. And always we are your mouthpiece to say, we have got also challenges that needs to be taken into consideration that make us not to perform, colleagues. And those should not be undermined. But we are also here to promote the HPV DNA cervical cancer screening among women of childbearing age and thus reducing the maternal deaths. And we are expected to implement that. And so far we'll hear where we are and come up with some of the strategies to improve the uptake of this. This is not new, and we have been doing this. We need just to strengthen. But also we are here today to raise awareness of the triple threats of the public and to promote action to prevent the vertical transmission of HIV, the syphilis and hepatitis B through prevention, early diagnosis, and the treatment of this infection. Together we can make it, colleagues, and this is the scientific platform where we need to discuss about all these challenges and all the good, not only the challenges, all what we have implemented. Together we can, colleagues. Thank you.
Thank you, ma'am. Thank you, ma'am. Thank you for that. I hope you got the purpose for the whole conference, the threads and everything. We know that midwives, you work very hard. You work very, very hard, and Namatala, they are just as many, but we appreciate you, midwives. We are all here because a midwife was at hand, gave birth to, they were there to assist, and that is why we are here. So thank you, midwives. Thank you, midwives. Thank you, midwives. Now, I'm going to go to our keynote address. yes, that's where we're gonna go now. I know that there's an item that says the introduction of the MEC, so the person that we'll be addressing will come. So now we'll be the keynote address speaker. We'll be calling Ms. Nomantu Nkomo Ralihloko, our MEC for Health and Wellness. She will introduce the person on our behalf. Thank you.
Ladies and gentlemen, I heard that my surname has been butchered. My name is Refile Mokhetle Motsamai. I'm the Acting Chief Director for Health Programs at the Central Office, and we'll be having the person who will deliver the speaker notes for the MEC, and I'd like to apologize on behalf of the MEC. She's not here with us. She has been delegated the role to the one person who is capable to do that, as he is. I repeat, he is. As he stands here talking to you earlier, you were saying he is all over and he knows everything. So our acting MEC for the morning is Mr. Pitsi, who is the acting Chief Director for the Sidibeng district, and Mr. Pitsi is a man of many talents. He is capable of doing a lot at one time, being in different areas at a time. Mr. Pitsi, welcome on stage. Thanks.
Having been here before, I thought I wouldn't be introduced. But thanks for the introduction. I've seen very few gentlemen here. And people talk of midwives, and they don't talk about couches. And I've had a few deliveries also under my belt. Well, I'll just go through the MEC speech as prepared. So whatever I say here, you'll pardon me. Program Director, Vice Chancellor and Leadership of Value University of Technology, DDG Corporate Services at Gauteng Department of Health, Ms. Basani Baloyi, leadership from the Provincial Office, Acting Chief Director for Sidibeng District Health Services, Mr. Motomoni Pitsi. Leaders from South African Nursing Council and Gauteng College of Nursing and our Nursing Directorate present here today. District managers, clinicians, researchers, partners, ladies and gentlemen, good morning. Thank you for welcoming us to Sidibeng and to VUT, where we gather for 3 days to learn, to share, and to renew our purpose together. As we open this conference, we do so with hope and with respect for the work you carry every day, because what happens in our wards and clinics shapes the story of every family in Gauteng. Our theme says it plainly: nurses and midwives, critical in every crisis, and the sub-theme calls on us to empower nurses so that quality care reaches every mother and every child in every facility and at every step of our journey. This is not just theory, it is a daily practice, and when we center nurses and midwives in our plans, the whole system becomes steadier, it becomes kinder and more effective. From the moment a woman walks into our facility, she should feel seen and feel safe, and that begins with a warm greeting that leads to a clear explanation and a plan she understands. When trust is built on those first minutes, adherence improves, follow-up becomes easier, and outcomes begin to shift. Therefore, compassionate communication is not a nice to have, but a clinical necessity. It is crucial to serving with a smile. We remain serious about the full journey of care, which means healthy pregnancy leading to a safe birth, followed by a strong start for the newborn and steady support for the child and family. Our nurses and midwives stand at the center of this journey because you notice danger signs early, you calm down frustrated and worried families, you connect patients to the right level of care, you carry this important responsibility, so we must keep strengthening respectful maternity care, improving handovers, and making referrals timely and simple so that good practice becomes the default everywhere. Over the next 3 days, let us make the program practical by learning from one another while asking hard questions about the gaps we still see. Share the small solutions that save hours and plans you have to cut waiting times. Share your tricks about how you improved night shift communication and how you keep mothers in care after delivery so that your wins become everyone's wins. As a department, we are pushing the basics that matter most, and everyday leadership turns them into lived reality. When we encourage early antenatal booking, mothers come into the system sooner. When we keep immunizations on schedule, children avoid preventable illnesses. And when we promote breastfeeding and good nutrition, we protect growth and brain development. Prevention is powerful when it meets people where they live, which is why we ask you to keep talking with families about clinic visits, medicines, and follow-ups, while also helping parents recognize warning signs. People return to places where they are treated with dignity. Therefore, let our tone remain human, let it remain calm and consistent, even on the busiest of days. Partnerships are our strengths, and today's partnership between the department, VUT, our training colleges, universities, councils, and professional bodies is exactly how service strengthens science and science strengthens services. When education, research, and bedside care move together, patients feel the difference and staff feel supported to grow. Colleagues, let us use this conference to move from talk to action by deciding what we will start, what we will stop, and what we will share. Start one new practice that improves safety or experience, stop one habit that does not add value, and share one change that makes a measurable difference in your unit so that this momentum multiplies. Managers and educators, your leadership makes teams brave, so please keep mentoring a young, healthy professional. Keep running drills that build confidence and debriefing after tough cases, because a supported team is always a safer team. As you recognize excellence, link it to learning opportunities. This improves skills and boosts staff morale. Clinicians on the floor, you carry the heartbeat of our service, and your calm presence in a crisis often becomes a difference. A steady voice, a clear discharge message, and a respectful handover travel with the mother long after she leaves the ward. And those moments of care build community trust into the health system. Gauteng is a place of possibility, and when we bring our heads, our hands, and our hearts to this mission, mothers leave our facilities with confidence, babies thrive, and families trust the system we serve. So as we begin, choose your next step, decide what you will implement first, who will be your partner, and how you will measure the difference by month end. Because small changes done everywhere become big results. Let us roll up our sleeves and make these 3 days count so that every mother, every newborn, and every child in Gauteng feels the difference. Thank you.
Thank you, Mr. Pizzi, for that. And now, Umme Anna will be presenting a small gift, a small gesture that was meant for the MEC. Thank you, Mr. Pizzi, for that speech. On behalf of Sidibeng and the Monarch, it's a small token from us. Thank you, sir. Okay. Thank you for that speech. What I take with me, they are saying that let us let these women feel seen. Let us make this, let's just establish good rapport with these women, basically. Just let them be part of the process, then they will cooperate better. Good practices will they need to become our default practice every day because prevention is powerful. So we need to encourage early antenatal, immunization on these babies, breastfeeding and good nutrition. It means all these problems that we face will fall away. And more than anything else, small changes done everywhere, they lead to big changes. That is what I take with me from this speech. Thank you, sir. And then next, I will be calling, I understand that we are still on time. Yes, on your programs, you will be showing that I am calling a speaker from the second one, but it's because we are on time. Sidibeng, we are on time. We are not late. Clock it, we are on time. So, I will be calling our next speaker, Ms. Zondi, who will be speaking on provincial MCWH indicator performances. Thank you.
Good morning, everybody, my seniors, all of them who are here, and safely to say protocol observed. Okay, thank you so much. It's a pleasure for me today to come and present to you on progress regarding maternal, child, and women's health directorate. It is flagged there and you can see it nicely. My name is Marosi and my surname is Mzondi, not Zondi. Thank you for that. All right. So this presentation is going to look at providing performance on progress, as I've just indicated. We're going to look at Q1, July and August. We have not yet received the full report for Q2. That's why we're going to end on August. And then also maternal, neonatal child health, and each stands for Integrated School Health Program Performance. And then we're going to look at the key challenges, reasons for underperformance, and also strategies to manage performance. And as we are seated here today, these challenges that we are going to mention are affecting each and every one of us, and it's up to us after this conference, or as we continue in our daily works, we need to make sure that we improve the situation. And for those indicators that we have performed well also is because of all your hard work, and we appreciate all your hard work. May the good Lord really bless you. All right. Okay, thank you very much. So we're going to look at the performance metrics. So with the performance metrics as MCWH and Nutrition Directorate, we have achieved 9 indicators in Q1, and 4 of them we did not achieve. Hence, we are at 69.2%, and indicators not achieved is 30.7, as I mentioned earlier. So it comes from us what it is that we are going to do, but I know we are all determined. Again, we are all determined to see ourselves performing better, isn't it? I can see smiles and nodding of heads. So yeah, we'll perform better. So the next slide is going to look at those indicators that I spoke about. And as we know, the green is reflecting that we have performed very well, and the red, we know that it means danger, and we need to do something about that. So we're going to start with the first indicator, which is couple year protection rate. As we know that couple year protection rate includes all the contraceptive methods that we are providing to our women out there and men out there, because we are also providing the condoms as a way of prevention and protection of pregnancy. So in the annual target is 43%, Q1 is still 43%, and according to the performance, as you can see it on the slide, we did not perform well in Q1 and also in July and August. We are below the 43%. And then with the delivery in 10 to 14 years in facility, those are our teenagers that we wouldn't like to see them being pregnant, but once they are pregnant, we are glad that they are accessing our health facilities so that they be delivered through your good hands as midwives. So the annual target is that we actually would like to see ourselves having 494. For Q1 is 124, and then with this indicator, fortunately, we have been performing well because they haven't been above the set target. In Q1, it was 89, and July and August, we can see that is below 30. And then with antenatal first visit before 20 weeks, we are encouraging that each and every woman who is pregnant should report early at our health facilities. And we are saying before 20 weeks, and we are actually saying once you realize that you have missed a period, you have missed your menstruations, we educate our young people that they must report. Not only young people, our women. We are saying they need to report at the health facility for them to be examined, for us to be able to see if they have any other health problem that will need to be attended to early enough. So our target is 71%, and in Q1, we performed well also in July and August because we have been above the 71% that is set. And then mother postnatal visit within 6 days rate. As we know, we are encouraging our parents, our mothers, to come back to the health facility post-delivery, and we usually encourage that at least after 3 days, so that we have, those days that she can still come back to the facility. So we have given ourselves 81%, and we have seen that in Q1 and also these past 2 months, we have performed well on that indicator, meaning that let us continue encouraging these women to come to the health facility with their children for them to be examined. And then infant PCR test positive around 6 month rate, the target is 0.5%, and we have been below this set target of 0.4, This also, we are doing well on it, but we know that there are those children after birth who are seroconverting. And I'm glad that with this indicator in the coming APP, we'll be also monitoring those even before the 6 months, because we know that there are those who are seroconverting even way before 6 months. And if we don't identify those kids that are HIV positive and we don't put them on treatment, we know that their life are at stake. So we want to identify them early enough and put them on ART as early as possible. And then the two indicators that we are not doing well on them: immunization under 1 year coverage. We know that we're encouraging all our children to come to our health facilities, the babies, to be brought to clinics according to the road health booklet, days, health workers in from the private facilities. So we encourage them to come. So with this indicates vaccinated. Hence, recently we had this measles rubella vaccination campaign in order to reach more children out there. And then with the next slide, we're still continuing with our indicators. There's an indicator that is talking to the child under 5 years diarrhea, case fatality. We still have children that are still dying out there because of diarrhea. Even if we are green, as you can see on the first diarrhea, even if we are green, as you can see on the first line, even if we are green, we're still not happy to see those number of babies dying because of diarrhea. The target is 1.7, and as you can see in Q1, we were at 1.2, translated to 17 babies who died in Gauteng. And then July also is 1.5, in August is 5. So that's why I was saying, yes, we have reached the target, but we need to do more, so that those parents, immediately when the child has diarrhea, they need to know that they have to rehydrate the child. Very simple, by giving sugar salt solution. We all have sugar in our houses. We all have salt in our houses. The recipe is very important. We still advise them to dilute 8 teaspoons of sugar in previously boiled water, 1 liter, and also half a teaspoon of salt, so that if a baby keeps on having diarrhea, we need to rehydrate that child, because if they are dehydrated, at times they even report to our facilities very late, and we encourage that once they have more than 6 stools, not stopping, having diarrhea right through, we encourage. So also with the pneumonia, we encourage that the parents should bring the children quickly to the health facility when they are ill. There are danger signs that they need to look at according to the integrated management of childhood illnesses. And we are saying that if they see a baby is breathing very fast, coughing continually, vomiting, and not being well, those are some of the danger signs that we need to encourage the parents to bring their babies to health facility. And also to take treatment the way it's prescribed, to take it accordingly. If we are saying 2 teaspoons or 5 meals, 10 meals, it should be 10 meals every 3 times a day, as we are explaining to them. Child under 5 years, severe acute malnutrition case fatality. We know with this one, they are sitting on our neck. We do well on this one. The target is 6.4, and in Q1, we managed to reach the target. And then in July, we are red, and then in August, we are green, and still we do not want to see ourselves having that number of children that are dying. So we need to make sure that cervical cancer screening, my boss will kill me for that. She spoke about that, hey? And remember, we have actually, I was not supposed to go there. Okay, with cervical cancer screening, that do cervical cancer screening. Don't say no cervical cancer screening. Don't say no, it's an eye care awareness event. We are not going to do cervical cancer screening. Let us integrate it in all our activities at community level, even in the health facilities. All right, I have. In schools, we are also vaccinating our young girls who are 9 years and above. In primary schools, grade 5, we are also doing catch-up immunizations in grade 6 and 7 so that we can vaccinate those children and prevent them from having future cervical cancer. We're still having a challenge with parents who are not signing consent forms. So we are, saying this so that even us who are here, I know we are most health workers, let us tell our relatives, our sisters to sign consent forms. Let us be the advocates of these children. School grade 1 learner screening. We are screening our learners in schools, and the target for grade 1 was 73,000, and in quarter 1 we were green, where we screened more than 34,000 learners, and when we screening is comprehensive, screening. And then in July and August, unfortunately, we are red, first time since, I don't know in how many years, but we know the reason is because of the recent measles and rubella vaccination, because everybody was focusing on that vaccination campaign. But now that is over, we trust that our colleagues who are screening these learners in grade 1 and grade 8 will focus and prioritize health screening. And please, let's remember that integrated school health program is very important, and we have realized that in other districts, they are not taking this program seriously. I know our chief, Mr. Pizzi, where you are, I know you are taking that very seriously, the program, your integrated school health program. So let all the districts take it seriously. Okay, and then HPV single dose learner coverage, I've spoken to it, and as you know, we are doing it biannually, but we have moved to giving the single dose. We are no longer giving 2 doses to these girls. So currently, there was no campaign when we wrote this report, but we know that our teams have just started now in October with the HPV vaccination campaign, and we will see progress in the upcoming reports. Okay, so with all those challenges or progress that we have mentioned, we're just going to go quickly through the reasons for underperformance, though some of them I've already spoken to them. Couple-year protection, we have noted that there was a decline with intrauterine contraceptive device insertion when we compared the quarter 4 and the quarter 1. There was a decline of about 272. So let us put more efforts into encouraging women to use the long-acting reversible contraceptives, of which one of them is IUCDs. And then also the inadequate capturing of private service providers' data on DHIS. Let's ensure that all those private providers bring their statistics so that they are included into our DHIS data. And always let us continue to do data verification throughout. With the cervical cancer screening, I think we have spoken to that, but we also need to look at the hospital data collection tools so that we capture each and every one of those women who has been screened. And we need to continue marketing our service. We are promoting that let it be health provider initiated, so that even you as a health provider, if a woman comes in, just ask her, have you done your pap smear? When last did you do it? And then you do it that time. And it should not only be done in one consultation room. That's why we did the training of our health workers, doctors on this cervical cancer screening, so that that is also done by other health professionals in other consultation rooms. And then with the delivery, 10 to 14, down there, we are promoting access to contraceptive methods, and we are still encouraging that. Let us encourage long-acting reversible contraceptives methods, including the implanon, to our young people. And also, as we all know, we are encouraging implementation of adolescent and youth-friendly services, where we are encouraging establishment of youth zones in our health facilities, because in all our health facilities, we are having young people visiting our clinics on daily basis, and we're encouraging that those young people who are visiting our facilities should be treated by health workers in a youth-friendly manner, so that we promote access to these health facilities. We don't want to see our young people or our women going even to backstreet abortions because our facilities are not accessible, because we are not friendly to them. So if we improve our friendliness to our young people, women who are attending our health facilities, the uptake will be good. Hence, in that first slide, we saw that our numbers are decreasing. It's 10 to 14 teenage pregnancy. And then immunization coverage was talking about that, and the reason we said there are still some of the mothers who are defaulting to bring their children to health facilities for immunizations. And we know that there are these problems that we are currently having in our communities, Sabo Dudula, whatever. So we need to pray hard, guys, that those should end. I believe in prayer some of the things can stop. So, so that our community are able to can visit the health facilities. Those who are coming illegally in our country should, stop coming illegally. Okay, advocacy and social. So we need to encourage advocacy and social mobilization to reinforce booking system and trace defaulter tracing. And then outreach campaigns, we are still conducting them, and we need to strengthen the public and private service provider partnership. And in Gauteng, we have got a signed SLA, and with that one, I mentioned in the previous slide, the importance of doing data verification. And then measles and rubella, second dose coverage, same thing. Mothers are defaulting, and with the mitigation strategy is the same one as the immunization under one. The school under one, school learner screening, I did mention that performance was poor because of the MR, and we trust that in the upcoming months, performance is going to be good, as our teams are going to prioritize health screening and also to improve this target. That's why during the HPV vaccination campaign, we also employ a number of temporary professional nurses so that they can assist our teams and end up reaching the target. And then in the upcoming year, we're no longer going to concentrate on screening grade 1s, but we are going to concentrate on screening the grade Rs, because in most of the schools, the entry level is at grade R, and most especially because the ECDs has been moved to the schools, so our teams will be focusing on grade R in the coming year. All right, I think that is almost the end of my presentation, because the upcoming slides are talking to the portfolio of evidence that we are submitting for each and every indicator that we have reported, whether performance or non-performance. That's why we sometimes trouble you people to ask for the POEs. So whenever we ask for portfolio of evidence, please do comply and submit all the portfolio of evidence that is needed. Thank you very much. That was all that I had.
Thank you, Ms. Zondi, for the report. Apologies for the butchering of your surname. Thank you so much. Thank you so much, ladies and gentlemen. That concludes our first session on my part for today, but I will now hand over to the chairperson for the day. Thank you so much. You guys look beautiful.
Kumnandi ukubalana. It's nice to be here. La utlwa accent ya teng e here. Colleagues, thank you very much. This concludes our first session. I would firstly like to thank the acting MEC for the beautiful speech. How we make women feel will determine if they come back for more services. We've seen Marosi presenting our work. That is not Marosi's work. That is us. Whoever is sitting there, province presenting all red, that is you. Even in labor ward, couple year, it's you. Antenatal clinic, EPI team, when the mother comes there, even if you are immunizing the child, are you checking, mommy, do you get family planning? It's our business, colleagues. Let us try and work on those indicators. And the speech from the MEC, wow, that was really amazing. It just says, let's talk to women, let's be kind to each other. That's all, you know. We must stop the historical teachings of making women feel like they need help from us or they're doing us a favor. It is by obligation and by commitment of us going into this profession to be able to treat them with compassion. So if I may plead anything for this conference, may we please unlearn the old ways of doing things and learn the new way. Respectful maternity care is the language of the day. Thank you, colleagues. We will break for tea. So for the guest speakers and our VIPs, Dr. Langa on my right will usher them to the venue for the tea. For the colleagues, there will be ushers at the back who will show you the venue for the tea. If we may please run with time. It's currently 5 minutes past 10. Can we please be back at 10:30, seated, refreshed, and you looking good, guys. Thank you. I will call upon the next facilitator for session 2, Mr. Jack Mohali. May we please kindly welcome him with a warm round of applause.
Morning, colleagues. Welcome you all to the 12th annual MONEC meeting. As she introduced me, my name is Jack Mihale from Ikuruleni. Ikuruleni people, thank you. Thank you. So I work in Polar Park, CHC. In the maternity side, so yeah. So I am an Akocha. I know. Where are my fellow Akocha? Yeah. It makes me feel better to see that we are being represented. I know there's only few of us in this midwifery profession, but. Yeah, because even me, when I arrived in Polar Park, there was no male in the maternity unit. I was the first one in 2020. So, yeah, as much as... Thank you. Yeah, so as much as it was challenging, you can imagine being the only male working in a midwifery unit. You know, people when they come in, they ask you, do you enjoy midwifery? And for me, that's a weird question because, yeah. So, yeah, I've been there, I've been working there since 2020 till now. So, which means I do enjoy midwifery. To prove that, I even went to UJ to study for advanced midwifery. I graduated this year. So. So yeah, currently I'm an advanced specialist. Thank you. So yeah, without wasting any time. But now at my clinic, at least there's another male who joined me. So at least we are two. So yeah, it's a bit better. I will also encourage him to study and stay with us. And hopefully the Department of Health, hopefully they create those posts for us. We are waiting for those advanced posts. Yes. So I'm gonna go back to the program. So previously we skipped the overview by the VUT. So I'm gonna call Ms. Maureen Mutsukunyani to come present. Let's give her a round of applause.
Good morning to you all. My name is Maureen Mutsukunyane. My position, I am the Director of HIV and AIDS program here at VUT. My role here is to welcome you. I would like to welcome you all to Vaal University of Technology, our world to a better future. We are very proud of VUT as it is the largest and the most distinguished university that produces engineers in South Africa. So on behalf of the Vaal University of Technology, the Vice Chancellor, Professor Ndlovu, and the Dean Student Support Services, I would like to welcome you all to this conference. It is also our privilege to have a collaboration with Sidibeng, District Health, and the Department of Health. And it is also a privilege that you have chosen VUT as a venue for this type of prestigious conference. I would also like to acknowledge the presence of our honorable guests here. I would like to acknowledge the presence of our MEC, if she is present. I actually arrived a bit late, I don't know. In her absence, she was supposed to be here. The MEC of Health and Wellness, Ms. Nomantu Nkomo Raloboko. I would also like to acknowledge the presence of the Chief Director of Sidibeng District Health, or the Acting Director, if she is here. And also acknowledge the presence of all the honorable guests that are here. All protocol observed. You are all welcome. My role here is to give you an overview of VUT in relevance to our student support services. Is there somebody who's helping me, or am I directing my own? Okay. Our purpose as student support services. Our first vision screen presentation slide starts with our vision, is to be the preferred university and system that provides comprehensive and holistic student support and development for our students. Our mission is to achieve and provide relevant and effective classroom learning in and outside of the classroom, and development services for our students, contributing also to the environment that is very conducive for our students, both for living and learning, and the development of positive impact to the communities that we are part of, and also prepare our students for a long life learning. Our values, we value self-responsibility, choosing accountability, positivity, and growth. We value teamwork, emphasizing consultation, openness, respect and fairness, integrity and dignity, valuing honesty, transparency, and the worth of all people. Our purpose is to together these components to prepare students for a world of work and life in general through education, leadership development, and holistic growth. And we are committed also to student support services to provide a wide range of effective programs and services that guide students from post-matriculation to the completion of their degrees, and provide continuous support for our students from the time they join the university until they complete their studies. Student support services has got 6 divisional units. Is student life and governance, that's where we find the SRC and student governance structures. And then we have the sport and recreation division. We have student accommodation, which is the residences. We have student counseling services. We do have psychologists and social workers. We have a student institutional HIV and AIDS unit. That is the unit that I'm leading with the HIV coordinators present. And then we also have a campus health clinic, which has got also emergency services like the paramedics. Now, ourselves as institutional HIV and AIDS, we align our programs with Higher Health, which is a non-profit making organization, but it is there to standardize programs within all higher education institutions, focusing mainly on the 10 priority areas, which is mainly the sexual reproductive health, maternal health, contraceptions, HIV, TB, and STI. We also focus on mental health programs. We focus on gender-based violence programs, including gender equity and transforming student mentalities. Substance abuse, substance and alcohol abuse, and including addiction prevention programs, youth resilience with care and physical well-being. We also have civic education program, which is also an NQF level 5 that our student peer educators complete and receive a certificate of NQ level 5 that shows their achievement. We also have disability units, and then we also have financial literacy programs that we take them through, also for them to understand the NSFAS, which is the funds that they get to assist with their studies. These are the programs that we usually normally have, like a student health and wellness. In the previous, we collaborated with Sidibeng District, and we held a health and wellness program with them, and it was such a success. We also collaborate with all other units. As I've indicated, there are 6 units. There's a picture there of the MEC when he was there with us, and we will provide sanitary towels programs and peer education programs. This is just an overview of what we are doing. This is basically a graph of statistics that shows our social mobilization, our student peer education, and our condom distribution. We do find a rise in our condom distribution, also in our peer education and social mobilization amongst our students. That is nearly all. Thank you very much. I don't know if I'm not going with you. Thank you.
Thank you for the presentation. Now we're gonna give the gift by May Anna. She's gonna give the gift to May Maureen. Thank you. Thank you for the wonderful presentation. So there has been a little bit of changes to our program. The item that is gonna come next, we're gonna skip for now the provincial Saving Mothers report. We're gonna go to the PPIP status update. It's gonna be an online presentation by Ms. L. Mashau. Thank you. Ms. El Mashau, you are online. You can start the presentation, please. You can go ahead. You are online.
Good morning.
Ms. Mashau, please share your presentation. Ms. Mashau, can you hear us? Ms. Mashau, you can go ahead. You can go ahead with the presentation. The slides are on. Apologies, colleague. Apologies, colleagues. There's just a slight technical problem, but they are busy solving it. So she will present in a few minutes. Thank you for your patience.
Good morning. Okay, good morning. Good morning. Yes, my name together looking at the national data from all the provinces across the country. Today I will be focusing on Gauteng data. I just want to put a disclaimer first that to apologize that because of the not being orientated on the facilities under Gauteng, we were struggling to know the pyramid or the facilities under each district. So I was made aware that West Rand was not highlighted, and West Rand were, I think, about 3 facilities that are reported as in good standing with the submission of PPIP. So I just would like to request that the province assist us to have the correct pyramid in future. Thank you. May I request the slides? I don't see the slides on my side. Correct, stop all the slides. Yes. Okay, in the meantime, just to go on with the presentation, from Gauteng we have, I learned that there are 6 districts in Gauteng, so we've got data from 5 of the 6 districts. Now that we have included the West Rand. And we also have the facilities from each district that have submitted. On my side, I don't have the slides. Okay, so I've been advised that I should just continue presenting. On my first slide, okay, thank you. I see there's the first slide, but can I add the facilities that have captured in the East District? And we don't have them on the slides. For Ekurhuleni, we have got data from 14 facilities. From Tshwane, we have got data from 20 facilities. From Sedibeng, we have got 8 facilities that have submitted data. From Johannesburg, we've got 17 facilities, and West Rand is 3. And the total of the facilities that have submitted data to our unit are 62 for the whole of Gauteng. And under the slide that is on the projector at the moment, we have got the graph that shows 2023, 2024, and 2025 submission of data. For 2023, we had just less than 50% of facilities in the whole of Gauteng that had submitted the data with complete data. And about in 2024, that has dropped drastically to less than 25% of facilities that were submitting data to our facility. And in 2025, that improved a little bit, but we are still at 25% for Gauteng. So we've got a lot of facilities that are not submitting data to our unit. Thanks. Next slide. The next slide is showing us the provincial comparison of all the provinces in the country that are submitting data to our unit. So if you look at the bar graphs, it shows about 1, 2, 3, 4, 5 provinces that have submitted the data that are close to 100%. That is Eastern Cape, Limpopo, Free State, Northwest, and Western Cape. Gauteng and Mpumalanga are the ones that are below 50% in submitting the data to our unit. So we've got a lot of facilities that are missing data from those two provinces. Next slide, please. In 2024, the picture for Gauteng became worse, as it showed even in our first slide, that in 2024, even those facilities that were submitting, they dropped in 2024. So when we look at the peak data for the nation, Gauteng is one that is really having very few facilities that are submitting data and are reported on our reports. Next slide, please. Yes, in 2025. In 2025, we looked at the data up to May 2025. And it also shows that Gauteng is still below 25% in submitting the data. So it's Gauteng and Mpumalanga, and KwaZulu-Natal this time is also very low, and Mpumalanga, they are the ones that are really lower in terms of submitting data to our unit. So we've got Northern Cape that has gone worse than Gauteng for 2025. Next slide, please. So when we look at Gauteng districts, sorry, we didn't include the West Rand here in this presentation, but I saw they had some data from 3 facilities. So we can see that Ekurhuleni is the better performing district in Gauteng in terms of submitting data. And then all the other districts are really at around 25% and below in terms of submitter for PPIP. Next slide.
Sorry, colleagues, let's keep our voices down.
Thank you. And in 2024, it also shows about just below 50% for Ekurhuleni, and CDB is above 50% and Channel. They are the 2 districts that have really tried to submit data for 2024. And all in all, Gauteng is still below 50% in terms of completing the data, which means when you say complete, all the months are submitted for that year. Next slide. Yes. So in 2023, the Ekurhuleni was performing much better and Channel for 2023 compared to the other 2 districts. So when you look at the whole of Gauteng, they are just above 50%. And that shows that in 2023, there were champions of PIP in the facilities that were collecting and capturing PIP data. And I suspect in 2024, we had some brain drain that those people were moved, and hence there's no continuity of submission of data in most of the facilities in Gauteng. Next slide, please. So here we looked at the perinatal mismatch. PIP data is not only about the completeness of the numbers. We are looking at why do babies die, why women die, and that we get it through the perinatal forms. If you look at the data, it shows us that in 2024, there were higher mismatches of the data. So that means in 2024, most of the facilities were not capturing the perinatal deaths. And it becomes like a DHIS if it doesn't have a perinatal form, because it's the one that is informing us why do babies die. And in 2025, Tshwane was better and Sidibeng and Joe actually better compared to the other 2 years. So we have got a lot of mismatches of data that we need to sit and interrogate those facility by facility. And unfortunately, we cannot fix this at a provincial or district level. It is done at a facility where you'll be having the forms that were captured and checking with the month of when they were captured so that you can see if all the deaths were captured. And to add to this, some of the mismatch, the transfers of babies that were born in another facility and referred to another facility, and they are captured without the denominator at the facility of referral. And we have agreed that we are supposed to create a separate file that is going to assist us to analyze those deaths of babies that were not born in that facility. So it causes a lot of mismatch. So that's why we said, for how then we request training so that we can share with the users on how they can deal with such discrepancies. Thank you. Next slide. So the solutions to this is we need a robust and coherent and well-established flow of data that should be checked at facility level by the stakeholders or the users who are actually capturing the data and validate it before they export it to the next level. Because when we come to a higher level, we cannot correct the mismatches, but they need to be corrected at the facility. Data should be continually captured and shared as mean through the district province. Then next slide, please. So my last slide is actually showing the data flow of the data from the facility to the highest level. So the proposed data flow is talking to from health facility, the data should be captured and sent to the district, from the district to the province. And then province, then it will come to our center for research center, maternal newborn and child health strategies, and we consolidate that report for the ministerial committees. For this data, we consolidate it for NAPENCO and we support national in terms of looking. And so the process is you start with the total monthly form and the perinatal data form as hard copies. And these hard copies should be captured and after that stored in a secured place. And then the deaths then can be compared with the monthly, and each death must be having a form. If you report that you had a death in that month, then the form must accompany that death. And then it's captured on PIP if it only is completely having all the numbers and all the forms together. And then we have to always routinely, before we export, check for validity of the data, of which in Gauteng, I found that a lot of facilities have got a lot of mismatches and discrepancies. Thank you. And I also had a slide in the other presentation that is not here. I was sharing with about the BARA data. Trisani Barabana In April 2024, their data shows double the counting of births. In other months, they were having around 1.2 births, but in April, they had about 2.7 births. So that also causes a discrepancy even at a national database. So this data, when we amalgamate it, it forms our national data for the country. So we hide the data before we export it. Thank you.
Thank you, Ms. Mushau.
And I'm going to request assistance from all the managers to assist us with the facilities in your hospital, in your districts, because we don't know them. I having some of the other facilities in my data, but because I don't know it belongs to us, because I have a database. So I don't have the pyramid from the Gauteng. So if I can be assisted with that, it could assist us to report better. Thank you.
Thank you. Thank you, Ms. Mashau, for presentation. I think one of the things we can take from the presentation is the capturing of data to ensure that the data is valid. So if we do have those maternal or neonatal deaths, we ensure that we capture on time to prevent those mismatches that she was highlighting. Moving on, we're gonna move to the next item by Ms. N. Mutserwa. She's gonna be presenting the Provincial Saving Mothers Report.
Thank you. Bye.
Good morning, ladies and gentlemen. All protocol observed. I am Ntabiseng Motsepe, the Assistant Manager for Maternal Neonatal Women's Health in the Johannesburg Health District. May I extend my apologies to West Rand and the other health districts in terms of the PPIP data that was presented today. If there's one district that is always on point in terms of submitting and reporting the PPIP, it's West Rand. We promise and assure you that in the NAPEMCO meeting that is scheduled in November, all data for Gauteng will be up to date. So it was one of those. It doesn't necessarily mean if your district today reflected as an underperformer, that's the end of the world. You still have time. So let's go and check our exports. Let's go and upload the PPIP software in our facilities, capture, export to your sub-district manager. Sub-district manager will export to the district manager, and will definitely share the information with Mayor Loli Mashau at the under NAPEMCO so that our data is up to date. In terms of making sure that our PPIP data is good quality, we are planning to schedule a training so that they teach us how to clean our data. Isn't it that we do have PPIP, we do capture, but we do not know how to check if it's good quality or not. So there is a training that we have asked that is scheduled for us to be able to get that, and that we know that we submit good quality data for Gauteng province. Disclaimer again on my part, presenting the Saving Mothers report. So today's report is not necessarily 2024 alone. I had then decided, let me just give you a financial year
type of report when it comes to saving mothers, because that then tells you, because most of the time we run towards the end of the financial year to the beginning of the financial year, so it will be appropriate for us to align our saving mothers report with that as well. We are aware that we have the triennial report that was released for 2020 to 2022. So now they are busy working on the next triennial report, but we actually get annual reports. We have received the 2023 report, and the team is working on the 2024 report. Just a picture of Gauteng Department of Health, our health districts. I heard Meloli saying we have 6. We actually have 5. We do have 6 colleagues in the PPIP. West Rand is divided into 2. That's why somehow she thought Gauteng has 6 health districts because of the system that she is using. We actually have 5, which is Tshwane, City of Tshwane, City of Johannesburg, West Rand, Ekurhuleni, and Sedibeng Health District. There we have, we're serving a population around 15.7 million to 16.1. As we know that on DHIS, our population is being reviewed. So those are the other challenges that we are having, to say that data in terms of population is being reviewed, affecting all of our performances in our indicators. So we have 259 primary health care facilities, 39 community health care centers, 13 health district hospitals, regional hospitals 9, tertiary hospitals 2, and national central 4 hospitals. In terms of the reason this is very important, colleagues, it's because of we need to follow the notification of maternal death. Whatever that appears on DHIS is exactly what should appear in the maternal death register in the provincial office. The maternal deaths that are assessed should also be tallying with everything else. We do have private facilities that your deaths that are occurring in hospitals, the private hospitals that are being reported as well. So this then tells you the importance of making on our side to make sure that we follow the correct processes when it comes to notifying death. And I would like to believe that all of us are aware of those processes when it comes to notifying of death, isn't it? Okay, so firstly, we inform the senior clinical manager in the facility. You inform the next of kin, and for them to arrange, and you need to also arrange supportive counseling. You also need to have a preliminary discussion of the death by all those involved. You notify the provincial maternal death coordinator. Fortunate for us in Gauteng, all facilities, all hospitals, we have a tablet that has been allocated to a health facility so that you are able to notify the maternal death that has occurred. That's where we capture it, and we also check if that data tallies with the data that we have on DHIS and also on the maternal death register in the provincial office. You inform the district specialist team because they are your first supportive team that needs to come in and carry you through that process. You discussions of death at facility through the MNM are being held. We complete the maternal death form, the maternal death notification form. Colleagues, we do not photocopy that form. That form needs to reach the provincial office, or regional form needs to reach the provincial office, not a copy. We do not copy it. And then finally, we do the submission of the maternal death notification form and copies of the relevant documents. Colleagues, it is very important to stress this. We are having challenges when it comes to the records that we are receiving as the assessors team. You find that the documents, one, they are not copied appropriately. That is actually the least of the problem. You do not write notes. You find that everything that you have done is not on paper. It is not on the maternity case record, and that is a challenge. So can we kindly go back to SOAP method? Let us write notes. so that when you copy a file, the person who's photocopying the file does not have herself or himself having so much stress in trying to understand the sequence of events or how to copy, which side to copy. But let us make sure that we record everything from a clinician. The first person who attended to the patient needs to make sure that they record all the information, and then we make sure that the quality of the copies that we do submit to the provincial office are of good quality. Because at the end of the day, that file is going to be used. Can I also say, can we not scan and email each other those copies, be it for the whatever meetings that are there and other committees that are there? That file needs to be held and taken with so much security, because we know all the issues that come surrounding the maternity case record. Then you are having comparing the 2 years. Yes, we are not at the end of the year 2025, but so far that is where we are. We are having 153 files that are already on DHIS, but the provincial office has not received them. It's concerning, colleagues. We need to really work on that and make sure all files are submitted in time. The top 4 most common underlying causes of maternal death, we have medical and surgical disorders, obstetric hemorrhage, hypertensive disorders of pregnancy, non-pregnancy related infections, just to lead the top 4. As you compare the financial years of 2022, 2023, 2023, 2024, and 2024, 2025, you see that there's a trend that medical and surgical conditions are in the lead. They are the highest cause of maternal death. Then you see the 3 following shifting positions now and then. That is your obstetric hemorrhage, your non-pregnancy related infections, hypertension, they take turns. And then we have the unknowns and the miscarriages also being in line of the 5 causes of maternal deaths. The DOAs, I listed them, which are most of the cases that we would find, and we cannot really conclude on that when you see the case, what could have caused the maternal death. So I just took each and every, the top 4, so I just took each and every one of them so that we are able to see what exactly are we referring to when we're saying medical and surgical condition disorders. We have myopathy, cardiomyopathy, which is the first in line. We're having 8 deaths, and we have endocrine, we have suicide, colleagues. That takes us to what we have included now in our basic antenatal care plus, which is mental health screening. It's very important, and it's not just an issue on maternal death, but we see it as a general issue to say mental status is a challenge and it needs to be given more attention. So may we make sure that that portion in your maternity case record is used and we screen these women so that they do not end up committing suicide. And we educate them that herbal ingestion will not really assist you in delivering in time. Tell them, laba ka ukwala, ba ukhatisa, cesarean section in Taiwan. So that they stop ingesting all these sorts of herbals we refer to in our traditional ways. Other cardiac diseases and neoplasm are the 5 causes in the maternal and surgical disorders. Medical and surgical disorders, I apologize for that. Hypertensive disorders in pregnancy, yeah, colleagues, yeah. We should be very far with this one. We are having eclampsia, pre-eclampsia with severe features, HELP syndrome, pre-eclampsia without severe features, and liver rupture. We have obstetric hemorrhage. Bleeding during cesarean section, not adherent placenta. Be worried. Bleeding after cesarean delivery, ruptured uterus with previous cesarean delivery, ruptured uterus without previous Caesar, uterine atony after vaginal delivery. In the non-pregnancy related category, infections category, we have other pneumonia, TB, PCP pneumonia, other meningitis, and other respiratory related infections. So this is just to give you a graphical picture of each and every health district. As you can see, medical and surgical is a concern, hypertension is a concern, obstetric hemorrhage and non-pregnancy related infections are a problem. We have miscarriages that are in all the health districts. That means we do have a challenge when it comes to one of the recommendations of the Saving Mothers, the availability of second trimester termination of pregnancy services, and also first trimester termination services. Because by now, colleagues, as our retired manager used to say, all CHCs need to offer medical termination of pregnancy. Another question, are we offering emergency contraceptive services? Do the community know that it is available in our facility, or they do not know? Avoidable factors re maternal deaths. So we have patient-associated and administrative, and we also have medical care associated. In terms of patient-associated, can I just take one, the lack of information? This does not necessarily mean patients do not know, colleagues. It means the file had no information. It means you didn't write. And then it appears as if, and there was information, there's something you did do the right thing, it just did not come out in the bed later. It didn't come out in the maternity case record, but you did it. But we did not see it. And remember, records don't lie. That's the other thing. So let's improve on that part, and we can actually win a lot of cases. Delay in accessing medical help is another issue, colleagues. I think I love the keynote speaker to say that, let's be kind. Just imagine if you would go to a clinic, just be kind. Just be kind. They will come to you. You know, I think we need to be more relaxed and leave out of work so that you can serve really with a genuine smile. No antenatal care. We're seeing that we're still having patients that are unbooked. They declined medication or surgery or advice. Colleagues, there are those cases, yes, they decline because, and there are those that you can tell that honestly she just wants to have a child too. Even if her condition doesn't allow her, she just wants to have a child. You know, so we have those cases. Those who defaulted ARVs treatment, we are having that trend, and urinary DTG, but we still have clients that are defaulting treatment. There's a lot of services available. I think one of the things that we are not privy to as midwives is the fact that we would understand what is happening in the primary healthcare part, what we refer to as the general side. They have 6 MMDs there. They have CCMDDs. Patients get medication, it clicks lately. So when we discharge them after their 6 weeks, we need to send them there. They don't necessarily need to go into the mainstream because they qualify. They are suppressed. So they're going back to work and they will not be able to come to the clinic with every month for those ARVs. So these are the other things that we need to be informed about. Organophosphate, as I've mentioned, the use of herbal medication, as I have mentioned. And then administrative associated, we have transport problems that can be from home to the institution. Oh, sorry. Technology is not technology. Transport problems from home to institution or from institution to institution. And I know in this house that is another issue, waiting time for an ambulance. I've called it, it did not arrive. Lack of ICU or ICU beds. We are having a huge challenge in regards to that. Delay in attending to patients. You see that patients are there, they do present, but sometimes we take time to attend to them because we have workloads setting out, the population is a lot, it's overcrowding and all of that. And then inadequate number of staff on duty speaks to the attending of patients, delay in attending to patients due to overburdened services, poor monitoring of patients, and delay in initiation of treatment. Colleagues, we're not saying you should be octopuses, but we're saying whoever that you are with, that you are rendering the service to, make sure that it is good quality. So that when you write to that patient or pepiling in another cubicle and you were not able to assist them, when we go back and check the one that you were assisting, we actually can see that you were giving it your all. Medical care associated, this is for all levels. I did not separate for CHCs, for hospitals, I just combined everything because those were the common issues. In most cases, colleagues, we must say, we have found that most maternal deaths, there was nothing we could have done. We gave it our best, but it was just time. Initial assessments, we see they are referred in time. Yes, we might speak that they are not referred in time, but they are really referred in time. You have assessed them, you have initially assessed them in your facility, and then you referred them. Problem with recognizing and diagnosis. We find that we misdiagnose our patient, and that means we will delay intervening in time. Delay in referring patients, incorrect management or wrong diagnosis, management at inappropriate level, substandard management, or when we have the correct diagnosis, prolonged monitoring with no action, not monitored or infrequent monitoring. What are the challenges that we have picked up? We have seen that there's an increased number of medical and surgical conditions, and that calls for multidisciplinary management or multidisciplinary approach in patient management, improve in availability and uptake of contraceptive for our patients. Contraceptives are there, but we now need to improve and make sure that we speak more about the long-acting reversible contraceptives. Early referral of patients is also important. Inadequate management of hypertensive disorders of pregnancy, late presentation of pregnant women with hypertension, we see that a lot. So we need to sit down and now write an SOP for nurses for initiation of aspirin as per latest EML guidelines. Continue with the implementation of basic antenatal care plus trainings, the M&Ms that are being held in our different facilities, and continue with ESMO training. Overcrowding in some hospitals, colleagues, this is another part that really needs primary health care. And only primary health care can assist us in making sure that we realize the establishment of ombus in our facilities, because we see that there's still overcrowding in higher level of care, and for us to be able to down refer those patients anyway, and we know the challenges that we are having with EMS, it will be appropriate for us to have an ombu close to those facilities, because honestly, colleagues, you'll find that patients will not be able to go anywhere. If you are in Bara and all taxis drop you off at Bara, there's no other facility because you only have transport for one, not double transport to and double transport to come back. So these are the challenges that we are having and we need to be looking into. My last slide, Chair. Poor auditing of safe cesarean section utilizing the HU2 by the hospitals. Colleagues, all hospitals need to do this audit. Then we'll be able to know when it comes to the standard of the facility. late diagnosis of postpartum hemorrhage. We've noted when we check the maternity case record and you look at that page, I forgot its page now, where we're actually supposed to be monitoring bleeding of a woman every 15 minutes, every 30 minutes before we can actually transfer them for postnatal, like every fourth stage. So we are not utilizing that. You might be doing it, but because it's not recorded, it means we are not doing it. Poor patient monitoring postnatally, that is another issue that we are having. The intervention is the use of the emotive calibrated under buttock drape. We encourage the facilities to order the NASC and encourage the use of early warning charts, the DCST, and facilities to continue with obstetric drills on obstetric hemorrhage. Province is progressively encouraging hospitals to accredit medical officers on safe cesarean section, encourage the use of uterine balloon tamponade when necessary. Colleagues, all of this depends on our demand plan. It is the demand plan season. May we have it in our demand plan so that we are able to order. Because if it's not in the demand plan, we will not be able to order them. And they are available. Delay in transportation of complicated cases to higher level of care. Escalation protocols has been shared with facilities. So EMS has what we call an escalation protocol, and I believe we're all inclined with that. And then we need to be able to implement it. It is available, and implementation of the EMS escalation policy and SOPs, and we're still asking for dedicated obstetric ambulances. We're still in engagement with EMS. They have alluded or cited their reasons why, because of shortages, but we're still continuously asking for them because we know in some areas the waiting time is too long. Interfacility shuttles by EMS are one of the solutions that we think will help us in our issues. With all that being said, colleagues, enjoy the rest of your day.
Thank you, Ms. Musawa, for the presentation. As she mentioned, one of the things that we should be practicing as midwives is being kind to the patient. Because these patients, when they come to the facility and they feel just, if you see a teenager and already is like their second child and you judge them, they're gonna, next time when they fall pregnant, they won't even want to come to the clinic. Then we end up having many cases of unbooked patients. So as she mentions, let's be kind, let's practice respectful maternity care. We are running behind on time, so I'm gonna quickly call Ms. Tira Matlo for the panel discussion on maternal, neonatal, and child health, addressing healthcare disparities in maternal and child health. So she will facilitate the panel discussion. Ms. Tira Matlo. Can we please have the microphones?
Afternoon, colleagues, or Saturday morning. Oh, morning. As introduced, and as I had introduced myself as well, I'm Deborah Mahlo, but now I'm coming in as a facilitator for the panel discussion that we will be having. I would like to call upon, so we will be on the floor because we are quite a number. So I'd like to call upon Dr. Tukisi or Mr. Tukisi. Akira basomo confer, Madam Chair, Madam Chancellor. Haso, but Dr. Tukisi pasita. I'll call Dr. Tukisi, he'll be my co-chair for this session.
I'm facilitating the session. Good morning, ladies and gentlemen. I would like to observe protocol in the interest of time, but I would also like to take a moment and thank each one of you for the love that you have just demonstrated right now. So I am Kagiso Tukisi and I am Doctorandus, Midwifery and Neonatal Nursing. So I am also friends with the Department of Health because I am producing the nursing and midwifery workforce for them, and that is why I'm here this morning. So, as it has already been mentioned, I will be co-facilitating the panel of discussion. So, to set the tone for the discussion that we are going to have, I'm going to quote and read here. So, the State of the World Nursing Report highlights the challenges experienced globally with the shortage of nurses and midwives. So, it also emphasizes the need for policy actions and the impact on health systems, gender equity, and economic advancement. So the report emphasizes that there is a need to invest in the nursing and midwifery workforce in order to achieve the sustainable developmental goals. So if we can think about what was mentioned this morning by various speakers, they put us, and by us, I mean the nurses and midwives, right there in front as primary care givers. So in order for all of these things to be achieved, it would mean we need to invest in the midwife and a neonatal nurse. The theme for this is nurses and midwives, again, very critical in every crisis. So, in order for us to attain all of these goals, ladies and gentlemen, there is a need, once again, to empower nurses and the midwives as catalysts for the quality of care that we want to see in the maternal and neonatal nursing context. So I am going to once again invite my co-presenter to take us through what is going to happen in this hour.
Thank you.
Thank you.
Thank you, Dr. Philosophy. We appreciate. Colleagues, now we're going to be on the floor with our managers on what Dr. Tukisi has just read. I will just briefly share the speech from the HOD of Health at the International Nurses Day commemoration that was held at Heidelberg Hospital. Yes. So the HOD, Mr. Lisiba Malotana, alluded to what Dr. Kagiso has just mentioned here, that indeed the State of the World's Nursing Report shows that by 2030, there will be a shortfall of 7.6 million. So it's still gonna get bad. So, but what I liked about what he mentioned is that always Gauteng Department of Health is on par. As we've seen, there's been a robust recruitment of staff currently. So we are trying to breach that 7.6 million. Without speaking on behalf of someone, I would like to call upon our DDG, Ms. Basane Baloy, to take the podium, please.
Abshin, Ninjani. Ipukile. My name is Basani Baloi. I am the DDG responsible for corporate services. And part of my portfolio is managing the Nursing Chief Directorate as well as GCON. I'm not a nurse, but I manage nurses. So. Yeah, if my age allowed, I would go and be an R171 student at GCON so that I can go through the words. But I am pleased to inform you that we have, committed as the department, as you could have seen, that there's a lot of work that we have done at GCON, as well as the Nursing Chief Directorate. We have prioritized nursing as one of our area of improvement within the department. Last year, we prioritized the area of neonatal, and we appointed around 250 nurses that were allocated to neonatal. The second aspect that we're focusing on now for this current financial year, which we also committed during the strategic planning session, is midwifery. And what we have also done is to look within the system, as to what are the challenges. The challenge that we have in the department is our employment options, as well as the recruitment, processes. And what we have done was to ensure that GCON train more nurses in this particular area. But also we have gone into the system and say that who are these graduates that have got midwifery qualification? So when I speak to the CEOs, and I'm glad one of them is here, he's following me. I don't think he's attending this. He wants, position. Speciality. Traditionally, people want somebody from somewhere, to fill that particular post. And we're saying that let's change the approach because it's not sustainable. If you appoint somebody from Kensani Hospital in Guyana, at Bar, I can tell you for free, that person won't stay for a year because the workload and the environments are different. But on the other hand is that we have got more than $1 billion in bursaries. So we have decided that we are going to train our own. So that we are not going to look for midwiferys for Sebokeng. We must train the nurses at Sebokeng who qualify so that when they become specialists, then the R171s will come in and then they be trained so that, we've got a larger pool. We have realized that we always look for, specialists from somewhere. Like now, if I've looked into the number of nurses that we have appointed, we've taken the retirees, instead of them spending more time with their grandchildren, we brought them back into the system. And when we bring back, I don't have a problem with them, and I don't want to be misinterpreted. They must come in and mentor those who would like to be midwiferys. In addition to that, we have also partnered with all universities. So if SENC has accredited GCON for only 250, we have partnered with UJ in terms of we are going to bring in more nurses into your university, and we are going to pay for them. I met with And I was told, I don't know how many matrons are here and how many managers are here. When we spoke to UJ, they said that our nurses do not cope with their program. Why? Because we release them to go and study and we expect them to come back and work. So we have agreed that we'll release them on a full-time basis and we pay them. So the other issue that we have, you know, sometimes you go and look for bread next door when you've got your own. I directed Mr. Serungwa to do an audit to say that let's look at how many specialty nurses do we have in midwifery and where are they? We've just discovered that we've got 100 of them and they are misplaced. They are either, you know, placed under professional nurses, general or enrolled nurses or assistant nurses. So it is our plan that we need to find money, 3 million, and advertise these positions. Internally, we'll ring fence them for the 100. So that, you know, we close that gap and that this 100 will have to move out of those positions so that we are able, you know, to appoint, you know, all our nurses. And I always say that we cannot have a college that does not supply skills to our hospitals. And one of the challenges that we have is a culture problem. And I say this all the time. You are a nursing manager or you are a matron because somebody gave you an opportunity to be where you are. So can we change our attitude towards the R171 nurses? And we accommodate them in our system. I'm not a DDG because I'm brighter or clever than all of you. It's because of other people gave me an opportunity to be where I am. So can we give the R171 an opportunity to work in our facilities and we guide and mentor them so that, you know, we improve services. We cannot train people in or nurses in our colleges and they sit at home or they loiter in the street and then we go and look for somebody from Guyana to come in and work at Sebokeng. It cannot be right. Because at the end of the day, we'll close GCON. And we need to plan our programs very well. I've seen, you know, even with the 500 nurses that we have appointed, and I have actually spoken to all CEOs that if you've got R171 or a post-ComServe nurse that you did not apply, you stuck with them up until you get money to appoint them. Thank you.
Thank you. Thank you, DDG, for that. I can see that the team is very excited that there's progress in mother and child. I would like to call colleagues, can we all be together here, please? Thank you. I would like to call upon the Nursing Directorate representative, Mr. Serungwa, the Director of Nursing Practice. He has a presentation for us that will be brief, then he will join the panel. Thank you.
Good afternoon. Is it still? Yeah. Yeah, good afternoon. Dimasiari. Dumelang. Sanbonan molweni. Awusheni. Let me acknowledge the presence of the acting MEC, Mr. Pizzi. I also like to also acknowledge the presence of the DDG Corporate Service member Louis and all the senior managers that are here and the representative from SANC, Dr. Mlepo, and all midwives and our coaches. I'm also one of the coaches. I started this journey in 1993. So it means 32 years back. It's not for the faint-hearted. In our first witness for delivery, when there was that crowning, you know the crowning, somebody collapsed during that process. Just to show that it's not for the faint-hearted. Otherwise, my presentation will cover this. We're given a brief by the team that was organizing to say we must have something, but they didn't give me a brief that I must wear like you. Then I said, okay, it's fine. As an culture, I will look for one of the elements of ABGA scoring, which was to look at the skin appearance. It must be pink. So I'm representing ABGA scoring. Yeah. So when midwives and our coaches are treated well, this will be the benefit that we'll get. As a system, maternal and neonatal motility and morbidity will go down. Then there will be improved birth outcome and reduction in the complications that happen during birth. Then we'll also get that good provision of newborn care and also the promotion of breastfeeding, and also the issue of health education we will benefit from that angle. And then it does not end there. It goes also to the society. When a woman is healthy, the family will be healthy. Remember, when she's not right, it affects the whole family. And then when she comes back with a healthy child, everybody will be happy to see that newborn playing with that child. Even the community will be happy that the population has increased. Then, remember, it will also affect the schooling part of it. If you have many school-going children there, they will build a school for you. So it goes a long way. Then it also affects the economy. If she is healthy, she will go back to work and then be productive there, and SARS will also be happy. And if she's also happy, the other thing that we will gain is that the healthcare costs will be reduced because most of the illnesses will be prevented through the knowledge of our midwife who is knowledgeable and they are coaches. Then the other thing is that this contributes also to universal health care, which is NHI. Then the mothers will get access to a skilled person easily so. And the whole program will support the implementation of our NHI. These are the midwives that we have in the province, with the exception of data from Tshwane District Health Services. They decided not to give us, I don't know for what reason, but they decided not. So we have got 2,335 midwives in maternity units. And we also have 4,662 nurses with midwifery qualification. And in total, we have got 6,997 midwives in the employment of the department, with the exception of data from Tshwane Health District. So what does this mean? It means that as midwives and all coaches, can we go and recruit from within? We have midwives somewhere in medical ward that you can recruit and say, can you come and join us? Then in the brief, they said we must indicate whether we have got a retention strategy for these 2,335 midwives and coaches. Then as the department, we have what we call employee retention policy. That policy covers 11 measures that the department is using to make sure that these midwives stay in the employment of the department. We are implementing PMDS policy. As you know, with PMDS, you get pay progression out of it. You get grade progression, which is an accelerated one, which you can move from being a PNA2 to PNA3, PNB1 to PNB2. Then we also we are giving people opportunities through training. You know, we are offering PEP, you know PEP, ne? Yeah. Perinatal education program, BOESMO. There is an 80-hour orientation on postgraduate diploma in midwifery that we are offering. We are also giving nurses study leave to go to GCON. Others are going to UJ and SMU. We also provide nurses with opportunities to attend workshops, seminars, and conferences like this one. You are here because the department gave you that opportunity. So the other strategy that we are using to retain the staff is through morale building. If you do well, I'm telling you, you are going to get a Staff Excellence Award. So keep doing well wherever you are. We are also having a policy on mentoring. So we are implementing that policy. Then the other strategy that we are using, we are trying to improve the work environment through refurbishment of infrastructure. If you go to Heidelberg Hospital, you will see what the department has done. That is one of the examples. Then, of course, we are aware that the workload is high. So we are having a policy on utilization of in-house overtime hours. And we are also, the DDG has indicated that last year we allocated post-commit service professionals in neonatal units. We are currently reviewing our organizational structure. Then the other thing that we are doing is talent management. We identify strengths and weaknesses from our nurses, and then where there are gaps, we make sure that we close those gaps through skills development. And we are also implementing OSD. And on top of that, if you happen to improve your qualification like what Dr. Tukisi has done using your own funding, I'm telling you, we'll give you a once-off cash bonus. Then the other strategy that we are using for retention is counter-offering. So don't be afraid to go for an interview for a higher post. Because if you go there and we want that skill, I'm telling you, we'll counter-offer you. That is what we are doing. Of course, there are challenges in nursing. We have got shortage of midwives, shortage of coaches. Of course, the resources that we have is not adequate. We know that, for example, you need CTG machines. Then there is also occurrence of patient safety incidents, which is one of our challenges. I think Ma'am who was there spoke a lot about these PSIs that we have. The first concluding remark, that first bullet, the DDG spoke about it. Remember, I report to the DDG. So she spoke about that one. Then we are in the process of developing safe nurse-patient ratio, like in labor ward, as you know, mostly when a woman is in labor, there is that time that there must be one-on-one type of care, which we understand is an ideal, ne? But for now, we are unable to reach this ideal. I'm not going to go to so. But I'm here with the DDG. That so will be answered. Then the last one, we want to offer debriefing for the midwives, that we know that sometimes you go through a lot in that space. So we will offer that debriefing. And also, that is our wish, that Midwifery Day be celebrated like International Nurses Day. So it is up to this team to say, do we want to celebrate it? What needs to be done? We are available to work together to celebrate the day. I thank you.
Thank you, Mr. Serungwa, scoring 2 under the parameter for the appearance, looking completely pink. But thank you once more for elucidating the fact that while we strive for better midwifery care, a midwife as well requires to be taken care of. So without any further ado, I'm going to call the Gauteng representative. Similarly to Mr. Serungwa, she has her presentation, a very short presentation, and she will be joining the team. So I'm going to call Mrs. M. Madumise to the front. A round of applause, please.
Good afternoon, ladies and gentlemen. You look so awesome and beautiful. Please give yourself a hand of applause. My name is Miki Madumise. I'm a lecturer for postgraduate diploma in midwifery from Harangua campus under Gauteng College of Nursing. I am standing in for Mrs. Pale Matlogonolo, which is the acting principal of Gauteng College of Nursing. So I'm just a messenger. Do not kill me because I don't have the armor. Without waste of time, this is the outline of the presentation for today. The purpose, it was actually to share information on the difference between the decentralized diploma in advanced midwifery and the current postgraduate diploma in midwifery. I'm not going to stand there, I'm going to stand in here because I am a lecturer. I need to see you just here. Thank you so much. Now let's look at the background for the DPAM. DPAM, it is the old advanced midwifery program, and I believe there must be candidates in this conference who undergone the DPAM. Now I undergone the R212 for 1 year. So here DPAM, when the DPAM started, I was still doing maybe standard 6, standard 5. Can't say standard, by the way. I study matric, and yes, I am old. I am that old. Now, looking at the background quickly, the decentralized program, which is the DPAM, it is one of the legacy courses that were regulated by the South African Nursing Council under Regulation 212 as an additional qualification for the midwifery. This program was only approved to be offered at KwaZulu-Natal province under the McCourt Hospital for a full-time period of 18 months. The students were recruited from all provinces in South Africa for theoretical teaching and learning in large numbers. There was no minimum or maximum intake of students then. The clinical placement of students, it was done according to provinces in clinical facilities that were not approved for KZN only according to the South African Nursing Council. For example, if you were a student coming from Mpumalanga, you would go and do your theory at KZN, and they would take you through the skills to be competent. Then you would go back to your province to practice the skills that I have taught you. Then after a certain period, you go back to KZN again for the theory and competency of the skills. So the program was facilitated by obstetricians and gynecologists, neonatologists, and advanced midwives, then without the master's degree that is required currently. The program was facilitated, the students were able to plant back all the skills required during the theoretical learning in their respective facilities. Now, all this information, I got it from Mrs. Mabasa, who was a DPAM student in the KZN. She's also my mentor. Now, let's look at the current postgraduate diploma in midwifery under Regulation 635. It is regulated by the Nursing Council, and it was published in June 2020, establishing the minimum requirements for postgraduate diploma programs leading to registration as a midwife specialist. Now, it is offered by the universities and colleges that are only accredited by South African Nursing Council and Council on Higher Education, and they must be registered with South African Qualifications Authority. You cannot provide this current postgraduate diploma if you are not registered as a nursing education institution. Students are recruited from all provinces for their theoretical teaching and their work integrated learning in the nursing education institutions, which are only accredited by the Nursing Council of South Africa. And the students are only placed for work integrated learning only at the clinical facilities that are accredited. Remember, with DPAM, we said you could place students on the clinical facilities that are not accredited. Now it has changed. You cannot place students to the clinical facilities that are not accredited by the Nursing Council. For example, currently in Gauteng or in Jikon, we have 50 intake of students from Rahima Musa campus for the postgraduate diploma in midwifery, and at Karangua campus, we have 40 intake of students for the postgraduate diploma in midwifery. We cannot place a student from Karangua campus, say to Baragwanath, which is accredited for Rahima Musa. Do we get that? Meaning, Rahima Musa can only place their student to their own accredited facilities according to the South African Nursing Council. Karangua must do the same. It must only place their student at the clinical facilities only at the accredited institution according to the South African Nursing Council. Even if we are all under GCON, we can't just place as we please. So the programs, the intake is actually from January to December. We do not have media intake. This is according to the guidelines of South African Nursing Council for Education and Training. The programs are also facilitated by lecturers with relevant master's degree in nursing, nursing education, and advanced midwifery qualification. Now, this is a problem currently, right? Yes, it's a problem because we do not have enough lecturers to teach the postgraduate diploma in midwifery. I'm taking this to the DDG to give the lecturers money. DDG, please. We need people. DDG, yes, you are here and you can see me. We have skilled personnel amongst us. Now, if you want to be a lecturer and you don't have a master's degree, you won't be able to teach the program. However, there are those that they have the education, they have the master's degree, but they cannot teach because there's no money. Right? Mm-hmm. Thank you. Now, higher education qualification sub-framework, it is aligned to the program prescribed that the facilitators, they must have a higher qualification than the program that you will be facilitating. You cannot teach the postgraduate diploma in midwifery because it is pegged where? At level 8. You have to have a qualification pegged at level 9, which is master's degree. Thank you. Now let's look at the difference quickly. We've got the DPAM, we've got the R212, which is a 1 year, and then we've got the postgraduate diploma in midwifery. Now DPAM was offered for 18 months. The post-basic, it was either 1 year full-time or 2 year part-time. Then the postgraduate, it was offered for a full 2 year part-time, or you can also offer it on a 1 year full-time base. Now with DPAM, there was unclear credit transferability. And then with the R212 post-basic diploma, the NQF or credit framing varied historically. Now, when it comes to the 635, the PG dips, the NQF level is at level 8 with 120 credits, and it is aligned with Council on Higher Education framework, meaning when you are doing this program, you can just go and do your master's level. The syllabi of DPAM was only offered at KZN, and then with 212, the curriculum was not standardized because each institution offering the program could do their own curriculum according to their own planning. Now with PG DIPS 3635, the curriculum is standardized, cut across, whether you are studying it at UP, at the college, GCON, or with Dr. Tukisi at UJ. We are all aligned now at level 8. Now, with DPAM, there was a large intake number of students. With the post-basic, the intake was according to the NACE enrollment plan. Now, with 635, the intake of students, it is per SANC enrollment plan. If SANC has approved for your institution to take 40, you cannot go above 40. You either take 40 or less, but not above that. I think that is the challenge currently, I get, for our bottleneck system in the clinical facilities. Now, quickly, let's look at the hierarchy of the education system in South Africa. We are starting at level 5. We've got the auxiliary nurses, I get. Now, they just need their matric, and then they can enter the program and be at level 5. Then the level 6, it is our R171, and also the R212, it is pegged at level 6, if you remember that. And then at level 7, we've got the current advanced diploma in midwifery, and then level 8, you've got your bachelor's degree, which is the 174, or your PGDs, which is the 635. Then you've got your level 9, and your level 10, which is the PhD. What has changed? We have changed from the fragmented apartheid era in training. Now we have the integrated academic and regulated speciality in South Africa. Now, currently, we have a clear legal regulatory framework legally recognized for independent specialist practice in defined domains. Remember, South African Nursing Council, they gave us a document for competencies of a midwife specialist, meaning that all the students that we are training, they must align to the competencies of midwife specialists according to the Nursing Council. The curricula is increasingly emphasizing advanced clinical reasoning, leadership, and public roles. Oh, Dr. Tukis, just 2 seconds. I'm about to finish. Just 2 slides, I think. So the practical consequences now is that with a student, they might struggle to articulate to further study because of unclear NQF credit recognition. Remember the R212? That is pegged at level 7. It's difficult. Level 6 is difficult for them to get to what? Level 8. Now, the educators of the college, they face pressure to revise curricula to meet the standards of the 635 according to South African Nursing Council. Now, with the employer, there's a struggle to compare applicants. They might also prefer to have specialists who have done 635 currently. And then with the health system, there's a risk that is of variable competency across all levels of cadres that are trained under the legacy versus the updated programs. I'm gonna be fast. Now, what is the plans to expedite midwifery training? This was a question given to Gauteng College of Nursing. Now, this is their plan, and I'm part of the Gauteng College of Nursing, unfortunately. Now, the plan is, currently, there's a support program that is running for 3 months so that the prospective student can access the PG DIPS program. Remember, they were pegged at level 6. Again, now they need, that is the R425, which is pegged at level 6. In order for them to become specialists, they have to undergo this 3-month program. It has already started. It started in August. They are writing or submitting assignment now at the end of October. Then next year, they're going to start as students for the postgraduate diploma in midwifery. There's also collaboration with universities for training Gauteng Department of Health employees for all the postgraduate diplomas. I think this one, the DDG has already addressed it, right? Yes, because now there was a collaboration between the Department of Health, the GCON, and the universities so that we can train more advanced midwife students utilizing UJ, your Sefako Magatu as well, because for UP, they have not yet accredited the program. Then there's also development of upskilling and reskilling programs such as short courses, which will start at the January 2027. This will also depend on the budget and human resource. With human resource, it's because of there is lack of lecturers currently. That is why they cannot start the short courses. Now, there's also short courses that are offered in the nursing practice. I believe that the previous speaker has alluded on those short courses, which are your PEP courses and your Bank Plus. And then there's also an upskilling program on Patrogram, which is done under UJ. I'm not sure if it has already started, but Dr. Tukisi will give us information around that one. There's also a part-time training for 2 years. But now this part-time training is a plan that has not yet been started, but GCON is trying to start the program. And then GCON also wants to negotiate with the South African Nursing Council to at least extend the curriculum, if possible, for 18 months so that we can include the basic ultrasound training, which is a need for our specialists. Now, there was another question that was posed, that was given to the GCON to say, would you consider going back to DPAM? Now, the answer, unfortunately, is no. Currently, it's not possible because of the two regulating bodies, which is our South African Nursing Council and Council on Higher Education requirements. Now, first, we must make sure that we continue with the programs that were accredited for, and then maybe in the future, then the new development of the DPAM might be considered. Now, because the problem, again, is that the impact of considering DPAM, there might be challenges due to the depletion of human resource, especially at clinical facilities. There's also the new curriculum that must be developed, be standardized, be accredited, and we also need trained mentors. Now, in conclusion, GCON recommends that the current program be continued in order for us to produce midwife specialists who are competent, independent, and content responsive to practitioners, and also be capable of reducing maternal and neonatal mortality and morbidity through evidence-based patient care in South Africa. Thank you so much.
Thank you so much, ma'am, for taking time, but we are going to still have a discussion on this program, but I am rushing towards welcoming the representative from the South African Nursing Council to come and share with us her presentation quickly, and just like everyone else, she's going to sit here and then she's going to be grilled by us. I would like to welcome to the podium Ms. Ash.
Good afternoon, everyone. All protocols observed. You've been hearing them the whole day, isn't it? But I would love to acknowledge our chairperson for Council, Dr. Mulepo, and one of our council members who actually does what I do, Miss Malaji. She's somewhere here with you. Okay, so this was supposed to be a panel discussion, in fact, as we were told, but here we are. So the purpose basically is information sharing on the regulatory mandates on midwifery practice in particular. But what I can say, I've heard a lot being said about knowledge. It has been shared, but knowledge is not power. The application of knowledge is power, as we have heard, that you are applying it. So it's interesting that things are happening at Gauteng, and you're doing very well, I suppose. Okay. So in short, the South African Nursing Council is the statutory body, a regulatory body, which has been established in terms of the Nursing Act. And its mandate is to regulate the nursing education and practice, and above all, is to protect the public, not nurses. I'm saying this because we need to be clear on what the Nursing Council is, because there is a confusion. We hear very acclaimed, very well-educated, well-qualified professional nurses phoning the council on employer-employee issues, or on SOD, or shifts, or just something that can be operational matters which the council cannot solve. So we need to kind of learn to understand legislation, and including our association, our unions, what are their role? So that will help you a lot, because we will look into what you do on the patient above all. So midwifery practice, that with preparation, and they've told you the programs that you have to undergo. That's clear, isn't it? We've got Regulation R174, we've got the Advanced Midwifery Program, which is undergone by the person who has undergone the 171, and basically now with those who have done the R683, who have not yet acquired their midwifery. So both programs are to prepare a nurse practitioner who will be able to demonstrate knowledge of people-centered midwifery and neonatal nursing care of patients in a variety of healthcare settings. So after preparation, the nurse educator have said it all. They teach you everything, isn't it? In order to acquire knowledge so that you can, and skills, so that you can practice. And with that, we have the scope of practice, which I'm not going to go through it because I know the nurse educators do that for you, isn't it? They teach it. So I'm not going to unpack the scope of practice here. But currently we have the scope of practice, the new one, which is the R2127, which have replaced the 2598. And then after all that, you are deemed to be competent. You have registered with the Nursing Council, you are licensed, and then you are ready to go to become an independent midwife or nurse. So that is good because you are competent, isn't it? So when you're competent, you are doing everything right, you don't need that to be investigated. But because life happens to people, it happens, including to midwives, and above all to advanced midwives. So myself, standing here, I do investigations of unprofessional conduct. And this is in terms of Section 47 of the Nursing Act. I hope you know the Nursing Act, isn't it? Which is our Bible of our profession, isn't it? So we investigate matters related to allegation of unprofessional conduct to determine if there is a case. If so, to determine if the case is minor, a minor offense, which you can just pay a fine and go on with your life. Or it's so dire that now you need to have a panel. You know, that's our court, in fact, isn't it? It's as good as being in a court to be in a PCC. So that one will call you, they'll contact you, they'll talk to you, they'll look for witnesses and everybody, including the complainant, who will come before them and explain what happened, what have you done to deserve that, right? So the PIC, which is the Preliminary Investigation Committee, is quite, it's independent, it's impartial, and the members cannot sit on the Professional Conduct Committee. That's, you know, to make sure that there's no biasness, isn't it? Unbiasedness, and it's, you know, subjectivity in it, isn't it? So that's why there are two committees constituted by different people. So the complaints usually are brought by public, individuals, healthcare establishments, which will be your managers, media. I'm sure with media, you know what's happening these days, isn't it? You need to watch your back at all times when you're taking care of patients. Because the minute you turn, the person who's behind you is a patient, including nurses actually, that recording everything that you're doing and send it to us. And yeah, that's a very painful act, in fact, because you find that you have done, you are just sometimes, it was true what you were doing because the patient has done something, they wanted to push on the floor, you were trying to help them, but someone now will misconstrue it and say she had an attitude, she was insulting the patient. Unfortunately, when it's like that, it's on the public space. There is nothing that the council can do but to call you to order, right? Yes. So, and then through the dedicated, we've got an email in which people can send complaints, and some can be sent hand-delivered, and actually, including yourself, you sometimes report your colleagues. And what I realized with colleagues is through, you know, squabbles, most of the time. And then, because you can resolve certain things, but you like to come to council. And the council actually ought to be the last place to come to, right? And anyone with information who wants to complain can complain. And then we will request their documents. So our role-based, our investigation is document-based. We don't want where you come and say, so-and-so said this, and then you say this. We can't prove it, right? As I said, that our role is to protect the public, who is the healthcare user, who must have received care from you. So obviously, whatever that you do ought to have been documented, or you were there, you didn't document. Someone actually emphasized it this morning, that most of the people do things, but they don't document. And unfortunately, when you don't document anything, it's to your peril. So, as we investigate, sometimes we'll come to the hospital where things are blurry, are not documented, and we want to find out what actually happened. I don't know if any one of you here has ever been found with an allegation or having appeared to the PCC. Have you been? Any? You are good midwives then. Okay, so the types of midwifery allegations that we normally investigate, the first one is attitude. Attitude. Nurses, the patient comes in, sister, I'm in pain, go and sit there. What do you want? Can't you see that I'm busy? You know, without even checking, trying to greet her nicely, receive her, do something for her, you know, just to allay that anxiety. They were talking about respectful midwifery, isn't it? So let that be our first point of care, of practice, isn't it? So that when the patient, you know, a smile can do a lot. A touch can do a lot. And these are the things that are lacking in the care. That's why we see a rise in complaints because of simple minor things that we can do, right? And then the dereliction of duty of care And incompetence, there are midwives who are not competent. They underwent training, but they didn't get it right somewhere. So these are the people who will deal with. And lack of clinical judgment, poor leadership. You know why I'm saying this? Some people even forge the register, you know that? And they managed to study and pass, but they didn't get the skill. They didn't practice. And then staff experience, this is one classic example of in midwifery. These nurses in this hospital have led to a patient losing her unborn baby on that night, last year actually. The patient was transferred to the hospital for fetal distress from a clinic. Then the second theater was needed to conduct an agency section. This didn't happen until the baby died in utero. The night shift had 2 professional nurses. On this night, the theater manager granted a vacation to the other one. So there was no staffing. So that's poor leadership. That's poor judgment, isn't it? So at all times, you must make sure that your ward is covered. That's one other aspect that we have. You have mentioned it as some of the presenters were presenting is staff shortage. You find that one midwife has 14 patients. What will you do? What will a reasonable nurse do in such a case? I hope that the TTG is taking that one is very serious. Because one thing for sure, one person cannot do anything. And we call that systemic failure. That's what we are going to take it to them, because we do share information. South African Nursing Council has to report to the minister on things that we think that the government can do something about it, the Department of Health. So continue negligence. Negligence comprises of 4 things. In fact, these days, patients are smart. They simply take a civil action for you. So there must be duty, there must be a breach, a causation, and a harm in order to prove negligence, right? So this is where you see that there's one case that we're dealing with around February, where a midwife, she was alone. She was in antenatal high risk. Then she monitored this lady, and then after that, she saw that this woman now the head was on perineum. But she told the woman to get off the bed to walk. Yes, to walk a distance, quite a distance. And along walking, then there are colleagues who are sitting like that, watching this woman walking, passing, and in front of them, the baby dropped. And what do you call that? What do you want to happen to you? Do you still want to be a midwife? So we've got medication errors, wrong medication, incorrect dosages, especially in neonatal ICU. Babies are given wrong medication, wrong doses, and unfortunately, they die instantly. Failure to assess the woman at any stage of labor, failure to monitor at any stage of labor, including the baby, wrongful termination of pregnancy. I'm sure this incident, it happened here, Ekurhuleni, where people were being terminated, pregnancies, wrongfully. Unfortunately, one case is too many. So someone was doing it. And then failure to seek assistance, failure to assess, I've said it there, and failure to diagnose, e.g. labor, that the person is in established labor, and then failure to give report or hand over to your colleagues, failure to call the doctor on time, failure to keep records. So this is how we manage our complaints. A complaint will be received, We'll check if it's within the jurisdiction, that's within the SANC ambits, and you have, you didn't do what you're supposed to do in terms of your scope of practice. There are acts and omission, we call it acts and omission, that will look into that. What did you fail to do in order for us to come after you? I'm saying it, come after you, right? Because we will. And if not, refer to relevant authorities, that employer-employee issue. And then if it's within our jurisdiction where the patient has been harmed, then we'll open a file, then we'll start investigating accordingly. Oh, yeah. And then we'll, I'll skip that anyway. And then based on the evidence, then there will be no negligence, we'll close the case, minor offense, then we'll fine you or caution you or refer you to PCC. So it will depend on the merit of the case. So these are actually our cases for 23, 24. Not much, but midwifery, we had 17 there, and 39 nurses charged. Yeah. Yeah, so thank you. The province, Gauteng, 20. So Gauteng has the highest anyway, highest in malpractice in all areas. Gauteng, KZN, number 2.
Thank you, Ms. Ash. Colleagues, I know we're running behind with time. Yeah, but that one was a bit shocking. Gauteng, we are the highest with misconduct. It's shocking, yeah. But then I'll give over to my colleague, Dr. Tukisi. Do you want to start? Okay, he gives me permission to start. So I'll start with our chief employer, DDG. I'll just ask a question based on what has emanated from your presentation and the other presentations, because we can see that there is a greater need for midwives and neonatal and child health nurses within Gauteng Health. And we've seen that the economy of a country or a nation lies in their health and healthcare system. If we are to look at the OSD policy that was passed in 2007, it mainly caters for primary health care as specialty. Midwives are within framework of general specialty, because if we look at compensation, PHC is always a grade higher than advanced midwife or specialist midwives. Is there a consideration that the department is making, maybe to review the policy, and maybe that would help in the retention of midwives? Thank you.
No, thank you. With regards to the OSD, we do not have, a responsibility with regards to that. That is a matter that is debated and agreed upon in the bargaining council. So the last time these OSD matters were addressed were around 2007. And the window will be opened not long, but we can put in our cases, with regards to nursing. So we will look at it because of their various occupations that needs to be submitted to the bargaining council that currently are not considered for OSD. Thank you.
Thank you very much, DTG. Colleague?
This one is always embarrassing me. But I would like to go to Mrs. Madumise on the program that you were presenting just now. And thank you for giving us the comparisons between the DPAM and where we are currently. And I saw that there are already the discussions going on trying to extend the midwifery training program that's postgraduate now to 18 months. But then I have also noted that there are also other things that we can adopt from the DPAM. Things like interprofessional education, where the obstetricians and the sonographers can actually become part of the trainers of this new program that you are trying to propose. How feasible is that?
Thank you so much, Dr. Chukisi. I believe we are one, which is Simonye, because we are all growing Gauteng together, right? And I think that is highly feasible if we communicate with the obstetricians and the trained midwife specialists who are currently conducting such ultrasound. So I think if we communicate together, we can actually partner and ensure that we teach our midwife specialists to be competent on just the basics of ultrasound. I hope I've answered you. Thank you.
Okay, thank you, colleagues or leadership. My next question will be posed to the Nursing Directorate, Nursing Practice, because I believe they will feel the most pinch. Currently, we are seeing a resurface of the brain drain, and it's mainly specialist midwives. From nursing practice, is there a plan that you have in place or you plan to implement in retaining nurses and decreasing the current brain drain? Because it's not only specialists. Previously, at least, other countries used to want 2 years experience, but now ComServe suffices. We even losing the neonatal or the midwifery. Is there a plan that nursing practice intends to implement or is in progress to retain the nurses?
Okay, thank you very much, Chairperson. As indicated earlier by the DDG, is that we are planning to replace the ones that are living, of course, and also to train other nurses through GCON and also through the universities that we are busy with the process of signing an MOA with them, which is SMU and UJ, as they are the ones that are accredited. And then the other issue is the issue of OSD review, like she indicated, is under national, it's a national prerogative. So they are busy from the directorate, chief directorate nursing at national. They have started something. So maybe what we'll need to do is to give them our inputs so that when they go for bargaining council, they can put in our input. Thank you very much.
Thank you very much. Thank you very much, and apologies for that glitch. But I want to go now to the South African Nursing Council, and temperatures were rather raised during your presentation, and we also heard that as Gauteng, we are the highest, and we really do not want to be the highest because we want to do the best. Is there anything that South African Nursing Council can suggest for us to mitigate all of this?
Okay, thank you. I think a lot has been said. It looks like you're doing something about it. Yeah, it looks like you're trying to do something about it because it's all about education, 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 and understanding your boundaries, your scope of practice, and communication with our colleagues. I mean, handing over, it's a necessity, isn't it? It's not optional. Calling the doctor when you are stuck, it's not optional, isn't it? You've got help at hand, but some professionals are not using it. They rather keep the woman, blood pressure, the patient comes with a very high blood pressure, is in labor, and you just decide not to do anything. So it's all about attitude. Attitude, understanding your ethical principles. You are there to help the patient, isn't it? To make the patient better. So do all you can. I think it's as simple as that. Thank you.
Colleagues, it all goes back to the keynote address, communication with our patients. Maybe we should stop using the word patients in women's health. You know, other countries don't use patients, they use women, bathing women. They are not sick, though there's medical conditions. Maybe once we leave the patient name, then we would be able to, I don't know, communicate better with them. But then I will open the floor just to 4 questions, 1 question per row. I'm selling once, twice. Can I have from the staff on the floor and not the leadership? I will stand to see. There's a hand, doctor. Can I please not take your question? There's a hand, 1, 2, 3. I will not take hands from the leadership colleagues. This is your conference, 4. Somebody to help us with the mic distribution. There, at the back. So it will be ma'am, 1, 2, 3, then 4. Then we close. Thank you.
Good morning, and thank you for the opportunity to ask the question. My question or concern is to the DDG. As midwives, we have nothing against the R171, but based on the SANG presentation, of course, they aspire to have midwifery, and they are not yet midwives. So in our department as midwives, there is not much that they can do independently without midwives. So indeed, if they are being prioritized above the midwives, it poses a challenge. And the plea is the ComServe program that we have, at times, it displaces some of the midwives. I can imagine, for now I'm in the West Rand, there's a midwife who was once displaced being at Sebokeng, far away from home, traveling, and for her it might be a challenge to even do handover. So if we get a directive to say the DDG directed us not to hire from, those who are already employed, that midwives who's being displaced will be forever being displaced. And the last concern is regarding the debriefing of the midwives. The current system that we have is not accessible. The telephone method that midwives need to be talking to somebody that they don't know, some of them, they find it difficult to get their emotions be addressed, especially when they have patient safety incident at night when there'll be no one, no psychologist is working night duty. So if maybe that could be looked into. My last recommendation would be...
Thank you.
Can I just say this?
No, ma'am. We have other speakers. We have to mind time. Thank you for that. Colleagues, may we please, we have many concerns, I know. Can we please, for time, And for the speakers, we will have an opportunity to speak to them during lunchtime. Can we stick to one burning question per person, please? Thank you.
Good day, colleagues. I just want to follow up on the question that was directed to the SANC regarding what suggestions that they have that we can do in terms of the misconducts that we as Gauteng have. We are currently the highest, right? And ma'am, you mentioned something about attitude and that we need to go on with education. However, during your presentation, I'm not so sure if it was yours or someone else's there on the panel, but somebody mentioned that we currently have shortages. You can find a one midwife with about 14 patients. Let's remember that we're not machines, we are human. You cannot have 20 patients, for example, in Leratong, we are always short-staffed. You cannot be one midwife having 20 patients and you are expected to smile daily with no lunch in between.
Colleagues. Thank you.
Good afternoon, ladies and gentlemen. I just have a concern with regards to training and education. I heard that they have allocated, let's say, they expect 50 students for Rahima Musa and 40 students for Garankua. But now the problem is that there are a lot of people who are interested in doing advanced midwifery. And even universities, when we apply, UJ will accept you, and then at a later stage, they tell you that there's not enough space. So I was asking is it possible to increase the number of applicants that are coming in, maybe to 70, 80, so that even the line can be pushed, even for the 171s to be able to do midwifery, as it is, I think it is the most critical part that is needed in the hospitals. Thank you.
Good afternoon, my leaders and colleagues. Ms. Gloria, I don't think you answered us when you said that education. We need clarity on what to do as Gauteng nurses, what to do to reduce the litigations and whatnot. Sometimes you can say, maybe you can send someone like working in-service training on what to do, especially what the sister has said. It's 100% correct. You need to assist us as SANC. Thank you.
Thank you so much. Let us settle to allow the panelists to respond to their questions. Ladies and gentlemen, thank you. We are going to start with you, the DDG, your question. Do you want to respond?
No, thank you, I'll respond. It would be irresponsible for me to say that appoint people who are not qualified. It will be very much irresponsible. But what I'm saying is there are opportunities for training, and I think we need to go back to the drawing board. When we look at the number of officials that are responsible for training in the department, it's scary, it's very high. You know, the life of a nurse, there is somebody in head office that coordinates training. There is somebody in the nursing chief directorate and HRD that coordinates training. There are the regional training centers. There are so-called C2s. There is a training facilitator in every institution around HRD. The question is, what is the impact of all these people. What is important is we need to go back to the drawing board. In-service training is very critical. We need to go back and do induction and orientation. For me, is that somebody that has never even done community service, probably they need to be on an induction program for at least a month or two before they are allocated to the wards. So it's something that we need to look into. And then the other issue that has been raised with regards to the shortages of skills, I spoke about it earlier, but we need to invest more in training, and we need to also make concessions. As I said, that you cannot expect somebody to be at UJ and then later on you want them to come back and be on night shift when you know that that person is also expected to study. So also in terms of the numbers, SANC can't just give us, an accreditation of 100. We also need to meet certain requirements. And we have realized that we might not meet them immediately, as we are also trying to capacitate GCON. We have given them an amount of around 14 million to appoint lecturers, but that is not enough. Hence, we're signing MOUs to ensure that our numbers, are actually adequate to can address some of these challenges that we have around midwifery. I think I've asked.
Thank you. Thank you, TDJ. Okay, the next question will go to Ms.
Okay. Yeah. I think on the shortage of midwives, maybe we need to be strategic to say, where do we want to start with the staffing? If we say, let's focus on labor ward, maybe we well-staffed like we have done to neonatal units. So that is what I can say. It needs to be done. The issue of debriefing DDG, that telephone calls are not assisting. Maybe we'll then need to talk with our Director for Employee Health and Wellness to come up with a strategy that can be user-friendly to all of us. Increase of intake, let me give to GCON, they will deal with this one decisively.
Okay, let me answer the question of training and education to increase the number of intake of students. I want to approach this question as a facilitator and give you an overview of what is currently happening. I am not GCON as I'm answering this one. I am a lecturer. We are having shortage of lecturers to facilitate the students that are currently under the program year 635, not because there's no appointment or there is no advertisement of post. There are advertisement of posts. However, people are not given the opportunity to train because of the money that is given to the lecturers currently. We have competent people around us which are midwife specialists with all the relevant qualifications, but because of the entry level, that's the problem. This is an issue that needs to be addressed, that we need competent lecturers, but we do not have them. Currently, as we are teaching the post-basic midwifery, you do get lecturers, 2 or 3, after 3 months, 6 months, they leave the system because there's more opportunities out there other than the Gauteng Department of Health. What they're offering us is quite little, and people do not want to come to PA and teach the postgraduate midwifery. By the way, I was not GCON, I was a facilitator, right? Now let me be GCON now. Now as GCON, we are regulated by South African Nursing Council, and they regulate the number of students that we must intake. It is prescribed by the Nursing Council based on the facilities and the resources that the department has. For instance, if we are conducting a work integrated learning module, the ratio is 1 facilitator is to 15 students. We cannot exceed that because we want competent midwife specialists at the end. So unfortunately for that part, we cannot have more intake because now it means now we will go above beyond what is prescribed by the South African Nursing Council in order for us to have competent midwife specialists. Thank you so much.
Thank you for the two people who actually retaliated on the matter of attitude. So on the attitude, I know the department or the government at large has got this document called Batupili Principle. Do you know it? Do you use it? And read with the Code of Ethics from the Nursing Council. Do you know your Code of Ethics? Do you know your ethical principles? Do you apply them on a daily basis? Then if it's yes, then the attitude will improve, isn't it? Okay, I'm still talking.
Colleagues.
I'm still talking. So the Batupili principles, we've got a code of ethics, and you've been taught professionalism, isn't it? I know that we have difficult patients. And so now this goes to nursing practice director. What are they doing with issues where there is bullying these days? Is bullying from the patients, there is bullying from the colleagues. Are they addressing those? Because those are some of the things that causes people's attitude to go negative. So are they addressing them? So they are in the house, they are listening, isn't it? Number 2, on the issue of I'm the one who raised the issue of 14 patients for 1 midwife, because it's based on the cases that we've analyzed, and we have them, and on those cases, we never punish a nurse or a midwife. We go after the nursing service manager, because we want to know what has she done. But at the same time, you as a nurse, you must also raise your voice. Tell your nursing service manager that I can't do this, isn't it? It's obvious, it's a no-brainer that you cannot do it.
Colleagues, can we please...
I'm still talking.
Ms. Ash, we are pressed for time. We are 30 minutes, 40 minutes behind it, right?
Okay, yes. So most of the things can be solved at home because the Nursing Council is simply a regulator. It wants to see that things are done and are done correctly, right? So, and at the council, on 6 monthly basis, the chairperson is here. She prepares a report on issues of systemic failure, those staff shortages, lack of equipment, and send it to the minister so that the minister can look into it and address. So they are here, the right people who will improve this. And then South African Nursing Council has introduced the CPD, in order to improve that education we're talking about, to make sure that you upgrade yourself, upskill yourself, isn't it? And then we've got inspections that are planned, where a crew from the Nursing Council comes around, do inspections, and they bring a report to the council, which the council take it very seriously. And it speaks to the minister and the Department of Health, the CNO, about them. So we are trying something. Sometimes we become devil's advocates, you know? You don't know how much we do in order to get you not to be disciplined. Thank you.
Thank you. Colleagues, that wraps up our discussion. The panelists are still here during lunch. You can have a chat to them. The managers that had questions, please chat to them. Otherwise, I would like to thank you for being a great audience. Please remain seated for lunch instructions because there was a bit of traffic during tea time. But I would like to request the team that dines on the upper right to proceed and move out first. Thank you, thank you, thank you.
Just 2 minutes. Just 2 minutes.
Oh, yes. There'll be gifts for our panelists. Anna, thank you.
Please announce only VIPs are allowed that side.
No one must. So should they remain seated?
Colleagues on my left, please remain seated. We've asked everyone to remain seated. Can we please remain seated? Please, colleagues.
When the midwife is a sage for me, it means wise woman. So we are the guardians of birth, aren't we? Round of applause for ourselves, please. Yes. So we're gonna welcome Dr. Molefe, who's going to be presenting the topic PrEP in pregnancy and breastfeeding women. So can we please give our doctor an ear to listen? Dr. Molefe, please come to the stage. Aram shapeleng matsogo, please.
Good afternoon to the leadership, good afternoon to the colleagues, and good afternoon to the esteemed midwives, obstetric clinicians that we have here today. My name is Dr. Gauhelo Molefe, and I am the clinical manager seconded to health programs at Province from Sidibeng District Health Services. Today, I've been tasked to talk to you about pre-exposure prophylaxis in pregnant and breastfeeding women. I know I have the converted here with me, so I will not be preaching, but I will be onboarding the unconverted. Ne? Please come on board this train so that we can learn more and understand the program so that we can benefit our patients. With that, thank you for having me and my directorate here, and you look beautiful. Once again, I want to reiterate that you look beautiful in your black and orange. We may start. So as part of the introduction, South Africa has the largest HIV epidemic in the world. We know that 7.6 million people who are aged between the ages of 15 and 49 are living in South Africa since in 2019. And we know that 4.7 million of the people in South Africa are on antiretrovirals. But despite this, there is approximately 121,000 new infections in 2018 and 2019. The World Health Organization recommends that HIV-negative people at a substantial risk of HIV infection should be offered HIV pre-exposure prophylaxis. And to also remind the colleagues, because we are currently in the 1.1 million Close the Gap campaign, that of these 1.1 million people, they could be our pregnant women that are accessing our obstetric care. So please, colleagues, we urge you, come on board, support the 1.1 Close the Gap campaign, and let's find our known positive patients who have disengaged from care and are coming back pregnant. Let's also identify, I thought, let me take this opportunity whilst we are introducing the subject. Here I wanted to paint the road of pre-exposure prophylaxis. Remember, I'm onboarding the unconverted. So to see the work done from policy planning to policy development from October 2015 to March 2016 when it was approved. We prepared in 2016 for the implementation in a phased-out approach, where we started with our key populations in 2016 up until date, where from PHC clinics in 2019, the phased scale-up commenced, and in 2021, we included the pregnant and breastfeeding women. And what was the guiding principles to this policy? We wanted to improve access. We wanted to identify individuals who are at high risk of HIV and ensure that access to HIV prevention and intervention, including PrEP, was attainable. We also wanted to integrate the PrEP services into other programs, such as the HIV prevention and the sexual reproductive health services that we have in our facilities. We wanted to provide PrEP within a broader framework of quality health services provision so that we could also improve the quality of care. We also wanted, as a public health and a rights-based approach, we wanted to empower individuals to have an informed choice of HIV prevention options using a public health approach. So what is PrEP? Pre-exposure prophylaxis. The WHO defines it as the use of antiretroviral drugs by HIV-negative people who are at substantial risk of acquiring HIV before potential exposure to HIV, so that we can prevent the HIV acquisition. We know that a substantial risk is defined as an incidence greater than 3 per 100 persons, which has been a huge gap in the absence of PrEP, and hence we want this policy to be implemented. The current preferred regimen in South Africa is an oral tenofovir and amitriptyline as a fixed dose combination. So it's a 1 pill, once a day dose. So we made it also easier for our patients to adhere to. Let us focus on the maternal and infant health care. What are the risks of HIV and PrEP for pregnant and the fetus? We know that for pregnant women, compared to non-pregnant women, they are 2 to 3 times more likely to have biological and behavioral changes. And I want to talk to this because we had one of the speakers talking about the mental health screening that is important in our antenatal care when we are seeing our patients. So with this in mind, can we as the clinicians taking care of our obstetric patients keep in mind that behavioral changes could also be linked to the mental changes that we need to look out for? We know another risk of the infection is that the higher level of the viral load, especially if it's a new infection in pregnancy, there's a higher likelihood to infect the baby. So these are the risks that we do not want our HIV-negative pregnant woman to be exposed to. What are the benefits of PrEP? I am speaking slowly on purpose, my colleagues, because just like the vaccinations have anti-vaxxers, we also have anti-PrEP clinicians. But I account that is probably due to hesitancy because we're not informed. And today with this presentation, we want to take that opportunity. Hence I say, I'm not going to preach to the converted, we're going to onboard the unconverted. PrEP is safe for the mother and the baby. Studies have proven that, yes, even though very low levels of the PrEP drugs are secreted in breast milk, they are not found to be teratogenic or to affect the fetus or the baby negatively. We know that PrEP is a good protection from contracting HIV, and I'm going to also reference to the latter speaker, who also pointed out that the #1 cause of maternal deaths is medical disorders. Could that be HIV? Something to ponder and think about. We know that one of the benefits is that for serodiscordant couple, they can plan to have a baby and conceive safely, reiterating our message of U equals U. Like I said, today we will know PrEP when we leave the conference. So I wanted to also make it just like we have GCON here, a lecture-based presentation, where we also talk to the differences between the pre-exposure prophylaxis, the post-exposure prophylaxis, and the antiretroviral treatment, which are all falling under the same pharmacological category, but are used for different purposes. So your PrEP is ARV medication, but not our TLD. Ne? So it's an ARV medication that is taken by HIV negative persons before exposure to HIV to prevent HIV acquisition. Ne? So this is a person we know is negative, but we know the risk of them contracting HIV is high, and we don't want that. Our post-exposure prophylaxis is also an ARV medication that is taken within 72 hours after exposure to HIV and is continued for 28 days to prevent HIV acquisition. Headlining, 28 days. It has a period that it's taken for. Mind you, we didn't speak about a period of how long they can take it for PrEP. Please keep that in mind, colleagues. Then we have antiretroviral treatment. This is lifelong treatment with antiretroviral drugs for people with HIV to minimize the effect of HIV by increasing the CD4 and reducing the viral load. So who are our potential candidates for PrEP? We know that we are now giving our PrEP to our adolescent girls, our boys, our young women and men. And where are they? They are here where we are hosting this magnificent conference in our institutions of higher learning. I will also talk to, when you see the new points, these are the updates from the 2021 guidelines, heart guidelines. And specifically to highlight on this slide is that pregnant and breastfeeding women have been added when previously they were not. So who is eligible for PrEP? HIV negative client by routine rapid antibody test. We want a rapid antibody test because we don't want the patient to come back for the results. We want on the spot, same day initiation. If the patient who is negative has absence of symptoms of any acute HIV infections, such as sore glands, esophageal candida, fever, or a rash, we would not count this patient as eligible for PrEP. Those who are willing and are able to take PrEP as prescribed. Remember patient autonomy. It's a choice. We can recommend, advise, counsel, but it's up to the patients to choose the treatment modality they want. If there are no contraindications to the tenofovir or the amitriptyline, we know that for tenofovir, because it is a renotoxic drug, and the presentation will talk to that in our practice, that it's one of the contraindications that we would not recommend this regimen for. Also because it affects bone growth. We know that adolescents who are greater than 35 kgs in weight are eligible, but if they are less than 15 years in age, an adolescent should be at tenor stage 3. So why are we speaking to the weight and the age? Remember, before the age of 15, bone growth is essential, so we do not want to stunt that. What are the contraindications for PrEP? And these are important for us to know, clinicians, because our patients ask us these questions. And what we want to highlight with the new ART 2021 updates is that we need to protect our clients' kidneys. So for our pregnant women, we need to monitor their renal function. And if their serum creatinine is greater than 85 micromoles per liter, that patient is not eligible to be put on PrEP. if that patient tests HIV positive, now has HIV infection, that patient does not qualify for PrEP initiation. So what does the guidelines say? It says, for PrEP in pregnant and breastfeeding women, we want an HIV negative woman who, these are the ones that we can initiate. When they come to our antenatal care for the first times, these are the screening or the criteria that we'll be looking for to who can be initiated on PrEP in our antenatal setting. So if an HIV negative woman who became pregnant while on PrEP, remember one of the slides spoke to the target audience for PrEP, and while they are on PrEP before pregnancy. So if they become pregnant, we don't stop that PrEP. We continue with the PrEP because they still remain at a substantial risk of HIV. We want HIV negative women who are breastfeeding and are at a substantial risk too of HIV. Those who are in a serodiscordant relationships where there is no evidence of viral load suppression in the HIV positive partner. I like the no evidence part because our patients always don't know their partner's status or their viral loads. So that is a criteria for you to advocate for PrEP. We want HIV negative women who are not on PrEP, but are considered to be a substantial risk of HIV contraction. And any appropriately trained healthcare provider is authorized to access, diagnose, prescribe, and dispense. So it can be a doctor, it can be a NEMAT authorized professional nurse, and a pediatric MAT authorized pharmacist MAT authorized pharmacists can initiate and issue PrEP. So we do not wait and say somebody's not on duty who can initiate. We look amongst our clinicians who qualify to initiate it. Importantly, before, we need the eligible woman to be offered PrEP together with acute HIV infection screening, like we spoke in our previous slide, to make sure there are no contraindications. We want to do adherence counseling. We want to do safety monitoring and a 3-monthly HIV testing that we will talk to. These are the baseline investigations. I know we had deliberations about shortage of staff, high patient loads, but let us not skim on the quality of care that we provide our patients. So even for our PrEP, our HIV negative, pregnant women who are on PrEP still need to be done baseline investigations. We spoke about the HIV test, which will be a rapid one to diagnose and confirm that they are negative. We are going to also take the baseline kidney function test so that we can assess whether they are contraindicated for the use of tenofovir or not, and also to monitor it, but the next slide will speak to that. An important one is to do your hepatitis B surface antigen in your pregnant woman. We are already doing it, but we also need to upscale it. The Acting Chief Director for Health Programs, Ms. Mokhetle Motsamai, spoke to the triple threat elimination strategy that is provided to block the vertical transmission of HIV, syphilis, and hepatitis B is one of the infections. We'll also do a syndromic STI screening and also a pregnancy screening to confirm. But even if the patient is not pregnant, when you confirm at that antenatal visit, they are still eligible to be offered contraception to prevent pregnancy, and you can still give the PrEP. All right. Wanted to highlight the importance of PrEP and hepatitis B, like we spoke to. TDF and FTC, which are the combination drugs in that one fixed dose combination, are both a hepatitis B, both have hepatitis B antiviral activity. So these are crucial drugs that you need in your chronic hepatitis B patient. So they are hepatitis B protective. So if discontinuation of PrEP in a hepatitis B positive patient is done, it could cause also serious liver damage resulting from reactivation of the HPV. Do we understand that, colleagues? Thank you. You are onboarding well. Thank you, my people. Some PrEP users may opt to continue using tenofovir to control their hepatitis, even if they no longer require the drugs for PrEP. Allow them and monitor them. How do we prescribe PrEP? The guideline recommends that the regimen is a 1 tablet by mouth, as we spoke to, that is taken daily. It can be taken any time of the day, so it can fit into the schedule of the patient. It can be taken with or without food, so it's not limited by whether you are hungry or don't have food in the house, and can be stored at room temperature. So at initiation, so after we do our rapid test, we find our patient is HIV negative. There are no contraindications. We are going to provide, and we initiate them on PrEP. We are only going to provide them with a 1-month PrEP drug supply. Why do we do that? We want them to come back after the first month so that we can assess adherence. So you will book them a follow-up month in 1 month, where we will repeat the HIV test to check and monitor if they are maintaining the negative HIV status. And then you will provide, if it's still negative, a 3-month prescription on our notes and a 3-month PrEP supply. So we can't prescribe it on the prescription, and our pharmacy only dispenses 1. Hence, we need our pharmacists and our pharmacy to be on board. The 3-month prescription should be dispensed with a 3-month supply of the drug. We want to promote adherence and patient autonomy. Then after the 3 months, they will come every 3 months to repeat the HIV test. And if they remain negative, we repeat a 3-month prescription with a 3-month drug supply of the PrEP. This slide is important, colleagues, and I would like us to share it with our colleagues and have it in our antenatal corners, in our facility, in our maternity delivery units, because this is the language that all of us here should be speaking to our patients to promote the uptake of PrEP in our patients, in our clients. Program director said we should change how we call our clients. So this talks to the risk-benefit counseling for pregnant and breastfeeding women eligible for PrEP. We want to talk to them about what is the risk of contracting HIV during pregnancy for the mother and baby. So this should be our bread and butter, colleagues, because we're not going to send them to a counselor to do this counseling. We, the clinicians, the bedside, are going to be doing this counseling with our patients. We also want to talk to what are the risks of the PrEP drugs to the fetus or the baby. This is an important question. All our pregnant clients have anxiety about the safety of their baby. And it is up to us as clinicians to give them up-to-date, evidence-based answers that will promote the medicine that we are practicing. We do know that very low concentrations of the PrEP drugs are secreted in the breast milk, as I previously mentioned. So we need to articulate it. But in the same breath, you need to tell them that the low amounts are still safe for the baby. We know that PrEP used in HIV-negative pregnant women was shown to be safe for the mother and the baby. We need to also communicate this to our patients, that we wouldn't prescribe them something that we know is not safe for them or the baby. There has been an extreme use of PrEP drugs over many years by pregnant women as part of the HIV treatment, and there have not been any indication of harmful effects for the infants and the... Okay. So these are the routine tests that we will do. Here I wanted to highlight the importance of monitoring the kidney function, especially when they have comorbidities. We're going to do it more often, and this is what the slide speaks to. This will be our PrEP pregnancy outcome reporting form. The previous speaker also spoke to data validity. This is one of the ways that we can also show that we are doing the work. So this will be part of our data capturing. These are the job aids colleagues that we need to see in our ANC rooms, in our obstetric delivery rooms that are up the wall, so that our clinicians are aware of the steps to take. Should change in shifts happen, should handovers happen, or should new staff come on board? These are job aids that are available from the department to share with the facilities. And with that, I wanted to stress that with this year's theme, the nurses wanted to stress that nurses and midwives critical in every crisis, and also the sub-theme, empowering nurses as catalysts for quality maternal, newborn, and child care. And with that, we'd like to thank you.
Hello again. Let's give Dr. Molefe another round of applause for that amazing information, things that we're already practicing, I hope. Another fun fact, some people think that midwifery is simply another branch of nursing. Midwifery is, in fact, one of the oldest professions in the world, one that is thought to have arrived prior to the nursing and medical professions. Did you know that? Right? So this also reinforces our next topic, which now we have Western medication that is helping us, and I hope we are making use of that. So let's welcome Ms. M. Chauke, who's going to be presenting midwives' experiences and perception on the implementation of maternal care guidelines regarding screening and management of hypertensive disorders in pregnancy.
Good afternoon, ladies and gentlemen. Yeah, they gave me 30 minutes, but now it's like I'm under pressure. I must present in less than 30 minutes. However, I'll try to do my best. Like they've explained, my name is M.M. Chauke, I'm Manchi Chauke. The rest of the credentials, if you want to know, come see me. I will explain them. Thank you. As part of my introduction, it's research. I know research somehow is boring a little bit. However, I'll just stick to the slides, quickly read the summary of the articles I went through, and then from there I'll give you the findings. While PPH, sepsis, and obstructed labor and complications from unsafe abortions are also major contributors of maternal mortality, hypertensive disorders in pregnancy accounted for approximately 14% of the maternal death globally. In 2020, the highest burden was seen in sub-Saharan Africa, and this was the research, the article, the information obtained from those guys. And significantly contributing to maternal mortality, which adversely affects socio-economic development and life expectancy. If you can look now in this wall, majority of people that are here are ladies. So if we lose one mother, it means the economic status of the country is going to be affected. We are the contributors towards our economic state. So we need to be careful how we manage our patients. STG call for reduction in maternal maternal mortality ratio of below 70 per 100,000 live births by 2030. And currently already we are in 2025, approaching 2026. The question is, are we going to be able to meet the target? Effective screening and management of hypertensive disorders during pregnancy are vital. Oh, please, I will. Up and down, each one to use here. Thank you. All right, I was saying effective screening and management of hypertensive disorders during pregnancy are vital, and studies highlight the importance of early identification of risk factors and implementing strategies to reduce complications. In the morning when I was listening, as they were presenting, especially the second session, because that's when I was here, I realized that hypertension is still a problem, and we need midwives to be able to screen. And if we are screening and we are able to early detect the risks, then we'll be able to manage those patients. So that was a concern from my side. And guidelines recommend that screening during ANC visits and identifying at-risk women and regular monitoring of blood pressure and proteinuria is important. I know in the morning they were saying they are thinking of prioritizing labor ward, equipping labor ward. However, if antenatal care is not equipped as well, then it means we will have more complications in labor ward. So basically, what I can say, we need midwives from preconception, move to antenatal, intrapartum, postpartum, continue, so that we ensure that we reduce maternal mortality. Therefore, midwives play a crucial role in identifying high-risk cases and initiating appropriate interventions. Where am I? Okay. So, Ramabona and Chira, they conducted a study and they mentioned that knowledge gaps, limited resources, and cultural challenges, they hinder implementation of guidelines. Incomplete record keeping, as stated, Sanka, they still here, it's also a challenge, and partial adherence to guidelines, they hinder implementation of guidelines. While delay in seeking medical attention, I know one presenter mentioned that as well, and reaching health facilities also contribute to maternal morbidity and mortality. However, hypertension remains one of the top 3 direct causes of maternal death in South Africa. Maternal mortality due to hypertensive disorders increased from 9.1% to 17%, and Limpopo reported the highest institutional maternal mortality of 1,579 per 100,000 live births between 2020 and 2021. And those calls, even though Gauteng we can do better, remember SDG says 70 per 100,000, like all of us. So Gauteng, if we are doing better, but Limpopo is still remaining behind. Some of us here, I believe originally we are from that side. And those are our mothers and sisters that are dying. So we need to go back and implement the guidelines. There is limited research on midwifery. So as a researcher, I realized, or actually there's limited research that is conducted where we want to talk to the midwives. I think it's Dr. Tukisi. He said midwives need to be taken care of. And you cannot love somebody without understanding their love language. And for you to understand their love language, you must talk to them and understand them so that you are able to take care of them. So I realized that it is important to conduct a research and hear from the implementers of the guidelines, or actually what are the challenges. Beautiful guidelines we have, however, we are still having mothers that are dying because of hypertensive disorders in pregnancy. Where am I? Okay. All right. Why did I do that? I said, what are the midwives? The research question was, what are the midwives' experiences and perceptions of the implementation of maternal care guideline regarding screening and management of hypertensive disorders in pregnancy? And this was conducted in Polokwane Municipality, Capricorn District in Limpopo. Okay, methodology, the research design was a qualitative explorative descriptive study, which is contextual. This was employed to gain the insight of the midwives' experiences. The research population, it was midwives who have at least 1 year experience providing midwifery care in primary healthcare clinics, community health centers, and district hospitals in rural and urban settlements in Polokwane municipalities. Sampling, we used purposive sampling, and this included 23 participants. Data was collected through face-to-face, semi-structured individual interviews, and Brown and Clark 6-phase approach to thematic analysis was used to analyze the data. Raiga was ensured, the researcher ensured trustworthiness by applying Lincoln and Cuba's 1982 quality framework, focusing on credibility, confirmability, and dependability. Ethical clearance was obtained from the university's Human Research Ethics Committee and Limpopo Department of Health. Participation was voluntary. Written consent obtained from the study participant prior to interviews. These were the findings. 3 primary themes emerged. The first one was midwives demonstrated caring practices enhanced by guidelines. The second one, they faced structural and systematic obstacles hindering the implementation of maternal care guideline for hypertensive disorders in pregnancy. And also they expressed structural obstacles limiting pregnant women's ownership and involvement in their care. I'll briefly describe them, trying to keep time. First theme, the midwives demonstrated caring practices enhanced by the guidelines. The sub-theme was empowerment for caring practice. They are empowered. They acknowledge that they are aware of the guidelines and they are trying by all means to implement them. And they also acquired skills and knowledge to provide the care. However, theme 2 mentioned that midwives faced obstacles hindering the implementation of maternal care guideline, and the sub-theme was structural and systematic obstacles. With structural obstacles, the midwives mentioned that they have shortage of medication, equipment, ambulances, staff shortage, lack of training, and frequent scheduled power outages, that is known as load shedding. This affected the implementation of guidelines. And also the systematic obstacles that were mentioned were poor record keeping and lack of managerial support. One presenter mentioned that lack of information is because we don't record. However, they explained why are they not really recording. So I just want to quote some of the quotations that the participant mentioned to support what they are experiencing. With regard to medical shortage of medicines, one participant noted that at the time in the clinic, we are out of stock and the patient is hypertensive. We want to give magnesium sulfate, then you find yourself only having 10 grams. Then you know how much are they supposed to give if the patient is having severe preeclampsia. We can't give 10, but they find themselves sometimes not having enough medication. Let me move to the other quote. Staff shortage significantly affects care delivery, especially during emergencies. Oh, sorry. I get bumper pressure. Where am I? Okay, I'll keep it there. So, one quote, one mentioned that the very two nurses are to attend to the ANC antenatal care patients. Then, if an emergency arises, they are the ones to leave everything and attend to the emergency. I think this was also highlighted this morning during the presentation, that we are expected as midwives to do a lot while patients are suffering. The other quote was, the problems are with the midwives. They said short staffing also affects training and guideline implementation. And then those participants said the problems are with the midwives. We don't read those guidelines. We are understaffed, always understaffed. So she mentioned that you leave the clinic, you are exhausted. You think maybe when you go home, you can go through the guideline. However, you are tired. You come back to the clinic, you are still tired. So they are unable to read the guidelines. Load shedding also was a problem, and one participant mentioned that during load shedding, we don't have access to phones. You end up using your own cell phone, thinking about the life of the patient. So you can see how much midwives are sacrificing their resources, because they were saying you want to transfer a patient, however, because of load shedding, the telephone lines are not working, and you end up using your personal cell phone to ensure that the patient reaches the hospital. Frequent network issues also hindered virtual meetings. Like this morning, we wanted somebody to present online. It was hiccups there and there. Things were not happening very well. So sometimes we think, okay, because we are short-staffed, let's organize virtual meetings. However, because of the load shedding, they had challenges with network, and these frequent network issues hindered virtual meetings and subsequent learning. And one participant said, we don't benefit from those virtual meetings. There's always a problem with network. Okay, poor recording also compromised patient care and the implementation of maternity guideline. This is what one participant mentioned. She said, sometimes we don't record. She acknowledged that sometimes they don't record. I think recording is a problem. We don't record. Another one said, if you can audit the files, you will find many mistakes, because nurses are always tired, always. Midwives expressed frustrations with maintaining accurate record due to overwhelming workloads, leading to rushed or incomplete documentation. You just end up writing the records just for the sake of writing. The only thing that they write is patient spend well. And then that's that. And then you go now, you must audit. The case is in sunk, nothing is written. However, you have managed the patient. Managers, that was a problem also. Managers failed to provide adequate support, with midwives reporting discouraging remarks that impact morale. Sometimes that is why we are down, because other ways that are uttered by our managers are not good. They feel unsupported by their managers and struggle with emotional and physical exhaustion. And we are very, very, very much committed to our clients. But sometimes when you wake up at home, you become somehow no energy. That's how they felt. Am I going to front or back? All right, I will just read quickly here. All right, the other theme was midwives express structural obstacle limiting pregnant women's ownership and involvement in their care. With this one, they were saying, due to poor economic social status, patients or women fail to adhere to visits and treatment. And sometimes women, remember, they've got so many responsibilities. They end up not prioritizing the care, prioritizing their children at home and not coming for antenatal visits. So I won't read what was mentioned there for the sake of time. However, you can see or it is a challenge with women not prioritizing their care. They reported that women, despite counseling, they refuse hospital treatment. There is a code, one of the codes that were mentioned by participants. Also, failure to adhere to visits and treatment. What I've realized in Limpopo was when a patient is identified as high-risk patient, was supposed to attend antenatal care twice. You still do your bank visit and also go to the hospital to be seen by the doctor. So it meant a patient will have 2 visits in one. When you go to the hospital, you are seen by the doctor, he does his work, then the following day you must go to the clinic, and that affects their visits to the ANC, and they don't adhere to what they are supposed to do. Theme 3, midwives express structural obstacles limiting pregnant women ownership. These were some of the codes that were mentioned. I won't go through them for the sake of time. Yes, okay, I got it now. And then the poor socioeconomic in the beginning when we started. So discussion, what we've realized is participants asserted that the guidelines instilled a sense of caring practices contributing to improved maternal and neonatal outcome. And it is important that maybe we can establish performance assessment as well and making awareness campaign to ensure that our patients are aware and having feedback and reflection mechanism in recognition of excellence should be, if it can be adopted. In this morning they were talking of debriefing calls, whatever those for debriefing of midwives. So it is important, that's what we recommended, that it is important that midwives should be given time to reflect and we give them feedback. Those mechanisms can also assist in ensuring that guidelines are adhered to. I won't read everything. So in conclusion, I'm passing everything. The study revealed the importance of facilitation, especially the need for more robust managerial support, training programs, and peer support systems to ensure midwives are better equipped to overcome the obstacles they face. Additionally, facilitating women's engagement in their care through community outreach and awareness campaigns could address some of the structural obstacles related to women's poor socioeconomic status. The findings highlighted the need for researchers and policymakers to investigate strategies to optimize the implementation of maternal care guidelines in screening and management of hypertensive disorders in pregnancy. Thank you so much.
Let's give her another round of applause as she's receiving her gift now. She did deserve that gift, hey? That was very fast. Anyway, let's welcome now another Dr. T. Ponyani, who will be presenting under the topic of respectful maternity care. I hope we give her the ear. Woo! Dr. Ponyani, is that you? Oh, he's on his way. Woo!
I try my best. I don't know, is it loaded on the system already? Is it loaded already? Is it loaded already? Okay. Good day, colleagues. It's an honor to be here. I feel honored to be standing in front of so many women here. I can count how many men are standing here. Oh, Mike, thank you. Good day once again, and happy afternoon. I hope we're all fresh and none of us are falling asleep. Esteemed colleagues, midwives, and fellow champions of men's health, it is an honor to stand before you as we reflect something very fundamental in our profession, which is respectful maternity care. Each of us here, seated here, made an effort to be here to celebrate this day. Childbirth is not only a clinical process, it is one of the most profound human experiences, a moment that can empower a woman for life or leave a scar for their entire experience in life. In South Africa, we've made a great stride in reducing maternal mortality, but many women still experience neglect, fear, and disrespect in our facilities. So therefore, today's discussion is about changing that narrative, reaffirming that safety without dignity is an incomplete care. As advanced midwives, we are caregivers, advocates, and leaders, shaping the culture of maternal services in the country. Let this be a call to all of us to blend skill with compassion, evidence with empathy, and clinical precision with human kindness. Together we can ensure that every woman who walks into our units feels safe, heard, and respected. So, why are we so obsessed with respectful maternity care? Because we have to approach it from a human rights point of view. It ensures a holistic approach, combining clinical safety with emotional well-being of every woman whom we interact with. It has to be integral to our maternal services and our healthcare services. It addresses the core mistreatment and coercion of our patients. As you might know, there was a case sometime last year of a patient who sued the Gauteng province for having been sterilized unknowingly also. She claimed to have been coerced by one of our doctors. So we need to be cognizant that these patients, they depend on us, and we need to be respectful towards them as well. We should also promote dignity, empathy, including trust, which improves our outcomes for both our services, both in public and in private. So, according to the World Health Organization, provision of care that maintains dignity, privacy, and confidentiality. It ensures freedom from harm, mistreatment, and enables informed choice, including continuous support for our ladies. So therefore, respectful maternity care aligns midwifery philosophy that is woman-centered, empowering, and humane to our clientele. So the several universal rights of childbearing women, these also are the guidelines for respectful maternity care. It's freedom from harm. Harm can be in any form, be it physical, verbal. We should always enforce informed consent. And the last speaker mentioned about choice. Most of the litigation that we're experiencing currently in our province in particular stem from informed choice or informed consent. Our patients are not discussed with antenatally what should happen to them as the pregnancy proceeds. So they find themselves having to take rash decisions because of our coercion. There should be privacy and confidentiality at all times, dignity and respect. Always observe equality and non-discrimination. As you might know, last year there was a huge hoo-ha in the province. I don't know about here in Joburg, but in Pretoria, many foreign nationals were refused care. And that didn't go well with the nationalities abroad. But we refused our foreign nationals care, and that is not in keeping with respectful maternity care. Our approach should be timely and of high quality. There should be liberty and autonomy involved for our patients. These rights define the ethical framework for all our maternity care globally, not only in South Africa, by the way. So these are the same guiding principles. They guide midwives, and they can also translate to respectful care into measurable daily behaviors, and that we can measure the outcomes as well. So in our context in South Africa, despite declining maternal mortality, there is a huge discrepancy with persisting inequalities in our systems. There's mistreatment in our overburdened facilities, cultural and socioeconomic barriers. The last one I want to talk about, I think many of you here experience it, staff burnout and low morale. Where are the managers? I don't know. DDG, I hope you are watching this one anyway. Yeah. So remember, respectful maternity care is both a system reform and a movement for human rights and equity included. So what forms of mistreatment do our patients experience? There are physical and verbal abuse. Currently, at Sebokeng Hospital where I work, a patient has complained that they were verbally abused by one of our sisters. There's a current claim now that we're going to attend to. So please, let's always be observant of what we say to our patients. Let's be compassionate, respectful. There's also non-consensual care that we give to our patients. Doing a vaginal examination without a consent is crime. Let's not neglect our patients. They depend on us, rely on us. Discrimination. Let's at all costs avoid it. Privacy breaches. Remember that mistreatment undermines trust and contributes to adverse outcomes. Therefore, recognizing these patterns is key to our prevention of these adverse outcomes. There is a policy framework available to us, and I think all of us are available to read this online. The Constitution is available, and it protects our patients, including us. The National Healthcare Act, Patients' Rights Charter, our maternity guidelines, HPCSA and SANC guidelines and codes are available online. And remember again, RMC is a professional and a legal obligation rooted in our system and our constitutional values. So anybody who goes and practices beyond this is liable. That is why we all have these bodies to audit us and always keep us in check, in line. So what are the drivers of respectful maternity care? They are both systemic and at provider level. Systemic, it's understaffing. At Sebokeng at the moment, we are, in my department, the nursing department is at 40%. I don't know about staff morale, but poor leadership is also involved from us, including our nurses, inadequate infrastructure. At provider level, burnout, compassion fatigue. Most of our colleagues are burnt out, are fatigued. Absenteeism, poor communication, also there, that is prevalent amongst our staff members. Therefore, sustainable, respectful maternity care depends on addressing both structural and human issues in achieving these outcomes and mitigating against the harm to our patients. So what are the evidence-based interventions that we can implement? It's having regular trainings, reminding ourselves of who we are, what we came here for. Encouraging birth companions that their partners can come with, be there, we communicate with them appropriately. Establish champions throughout the province in each and every hospital. Introduce feedback mechanisms for each and every hospital as well. The last point is very important. Recognizing positive behavior. I don't know when was the last time a head of the unit recognized their nation staff in the unit. Say, let's say thank you for achieving a good week, month. We are all in a blameworthy, always blaming each other, never appreciating each other. So it's about time we start showing appreciation to each other. These evidence-based approaches strengthen empathy and teamwork, and together we can do better and achieve more. So what is the role of an advanced midwife? Again, let's apply a model of compassionate care. Promote informed consent. It keeps coming up, it's very, very important. Mentor colleagues. How many of us are mentoring colleagues? There's a colleague I saw here during the lunch, and they brought their subordinate. How many of us put our subordinates here? I don't know. Let's also lead quality improvement objectives and initiatives to try and improve ourselves. Advanced midwives are catalysts for cultural and systemic change. So you are very important sitting here, guys, and give yourselves a round of applause. Yes, here we are. I'm getting lost here. Yeah? I'm not done yet. Okay. Nonetheless, I don't know. Slide number 15. 15. Thank you. Thank you. I'm looking for a pointer actually. I don't know the point. I keep pressing arrows. Yeah. So, importantly, we should involve in our audits every month. Respectful maternity care. It's one of our performance indicators. Let's not lose sight of it. Let's track incidents, conduct feedback sessions amongst ourselves. Also in our death audits, we should actually include this in our death audits as well. At Sebokeng Hospital currently, this is my envisaged model where we are included into our orientation on an annual basis. When we employ our new staff at the beginning of the year, we'll have an orientation, have empathy, peer empathy sessions, where we can give feedback, because we don't do feedback sessions in the mornings. Nurses experience outcomes that are poor, and none of them ever get time to debrief. Feedback systems, recognition of compassion. Again, talking to somebody, your senior, I've had a bad outcome. Most of us go home, bitter, angry, and we come back the following morning, and we give the same bad energy again. So this is our approach at Sebokeng Hospital that is envisaged for next year. So towards the culture of respectable care, it's achievable and it's evidence-based. It requires leadership and accountability. It aligns with Sustainable Development Goals 3.1 to reduce maternal mortality, and it's at the center of it is maternal dignity. It's a moral care of quality for maternity care, maternal safety, empathy, and respect. So as we close, let us remind ourselves that respectful maternity care is not an abstract policy, guys. It's a daily expression of our professional integrity and humanity. Every act of compassion strengthens families and systems. Let us lead with empathy, mentor with kindness, and serve with courage. When women are respected in childbirth, families thrive, and humanity is uplifted. Thank you.
Thank you, Dr. Poanyani. Let's clap hands for him again. Tsogang, guys, tsogang. We are almost done, eh? Can you please welcome to the stage Dr. M. Makhata, who's going to be presenting for us PTSD prevalence and clinical correlates among an antenatal population in Sidibeng. Can you please clap hands for him as he comes on stage? I hope he's prepared and his laptop is already ready with the slides.
Good afternoon, colleagues. Lebitso ke Mojalefa wa Hamagata. This particular presentation, colleagues, is actually part of an MMed study by Dr. Pfeiffer, who's currently writing her final exams. Hence, she couldn't obviously be here to present. So as one of the supervisors for her, my apologies, as one of the supervisors for this particular master's program study, I will be presenting the findings. In terms of this current study, colleagues, around post-traumatic stress disorder, in an antenatal, the prevalence and clinical correlates among an antenatal population in the district. I think it's quite important, colleagues, to indicate that like PTSD is mainly associated with a marked impairment in functioning. What that means basically, colleagues, is that like obviously when you do present with a mental health condition, and most of them, colleagues, depending obviously on the severity, it really affects a person's capacity to function. And it really affects a person's capacity, obviously, as a mother, to bond with the child, to really care for this particular baby because of that mental health condition. And women who are pregnant in particular are considered a vulnerable group. As you know, in this country, around issues of GBV, I think PTSD obviously also tends to be quite high among women. And perinatal PTSD, colleagues, as I've indicated, is important because of the functional impairment on the mother and the impact that this is having on the mother-child infant relationship. And in terms of prevalence, colleagues, how common is this PTSD among our population, our women who are pregnant? The figure is quite uncertain, but if depending on which country you are looking at or the study that you are looking at, you could be looking at anything between 0 to 40% in terms of prevalence. And then in one particular study in the country, which is called the SASH study, which was a more representative study that was conducted for the entire population mainly, that prevalence stands at 2.3%. And then here in Gauteng, in a so-called a localized study, because this is where we are currently located, a study conducted in 2018 placed the prevalence at 11.6%. So we basically thought, it might be quite interesting to look, if you come closer, to look really at Sidibeng and how are the figures looking like in a context like ours. And therefore the aim and objectives of the study, colleagues, was mainly to determine the prevalence and associated factors of PTSD in an antenatal population attending a community health center. And we had 3 objectives, which is to determine the prevalence of PTSD in an antenatal population, to describe the socio-demographic and clinical characteristics of women attending this particular clinic, as well as to compare those women who had PTSD and those who did not have PTSD in terms of their socio-demographic and maternal health factors. And in terms of the method, this was a cross-sectional study using investigator-administered questionnaire, and we also had to use a questionnaire looking at the socio-demographic as well as the antenatal history. And then we also then administered a PCL5, which is a post-traumatic stress disorder checklist, which is mainly made up of a 20-item, which is scored on a 5-point Likert scale for symptom severity. And in terms of sampling, it was really a convenience sampling in the sense that like women were recruited on the day as they were visiting the clinic, and we had really targeted to get at least around 100 participants, but we ended up with 98 because 2 of the women had to be pulled out of the study due to experiencing some discomfort and some stress. Obviously, you know, once you start talking issues of PTSD, you know, really some women, you know, some of these traumas, they could be quite recent. So for ethical reasons, obviously we had to pull them out. In terms of the results, colleagues, as I've indicated, that like 2 women had to pull out of the study. 98 pregnant women aged between 18 and 40 years old eventually participated in the study. And of those, 82% were Black African, 10 were white, 5 colored, and 1 who identified as Indian/Asian. And then in terms of education, the attainment of education for this particular group was limited with 40 participants obtaining matric, 38 had some tertiary level, and however the unemployment rate was double the national official unemployment rate. And 34 of these participants were single, and 63 were in a relationship. 24 participants had comorbid medical conditions, and 37 participants reported using substances in pregnancy. And 6 participants had a score of at least 1 on routine antenatal mental health screening. However, no detail was provided on intervention strategies that were provided after they've screened positive. And 8 participants described having some prior mental health care utilization. And then 53 women reported having experienced or witnessed a traumatic event in their lifetime. And in 14 women, the traumatic event was linked to previous obstetric or gynecological complications and neonatal demise. And 4 reported experiencing IPV, and 3 had a history of childhood trauma, one of whom was currently exposed to IPV. And the remaining participants reported a history of trauma, did not wish to disclose it. And then 16 women screened positive for at least moderate PTSD with a score of 31 or above. And I'm not sure, colleagues, if you will see this. Basically, this particular diagram really speaks to those women who really, the 16 that scored positive on PCL5. And the area that like was mostly elevated, as you can see, It was more around them experiencing negative alteration in cognition and mood, because these are clusters within PTSD. And generally speaking, colleagues, there was no statistically significant differences between those with and without PTSD for any variables except for drinking 2 units of alcohol per day, which was more frequent among those with PTSD, and no variables were significantly associated with PTSD on a univariate analysis. So basically, where you are just looking at one variable, nothing was significant. Where you were looking at multiple variables, alcohol was found to be significantly associated with PTSD. And as I've indicated, colleagues, because as you are dealing with issues of trauma, we had obviously to enact our distress protocol, because ethically, I think you'll agree with me then that, it's not just about doing research, it is also about identifying when people are distressed and they might not have really had an opportunity to access help. So 53 of those women who exhibited some form of distress and were referred for a mental health professional. This was either for PTSD, interpersonal stress, substance use, and poor social support. And then 30 participants were referred to a specialist mental health service, and the remaining to a social worker or a registered counselor. Colleagues, I'm going to rush through this because I can see our program director is here. I suppose that's the disadvantage of presenting last. In terms of the discussion, colleagues, as we conclude, as I've indicated, 98 pregnant women participated. 16% of these participants had at least a moderate PTSD on the PCL5 questionnaire, and alcohol use was the only factor associated with PTSD. And the prevalence in terms of this particular population for CDBing, the prevalence was greatly exceeded the prevalence of PTSD found in the general population in terms of this country, which is 0.6% in the SESH study, and similar to other prevalence rates among high risk groups of pregnant women in international studies, which was around 19.7%. So there was no directional causality to be determined from this study, and it is unclear in the literature as to whether there is a causal relationship between alcohol and PTSD. But in our sample, we can indicate that alcohol use in pregnancy is very concerning, colleagues. And overall, as we've indicated, around this population that is using alcohol, that the national rate of alcohol in pregnancy in this other national study, it was around 3.7. And of concern, colleague, is the poor identification and referral of mental health conditions in the routine antenatal care, and the lack of mental health care is consistent with the treatment gap of 75%, which was found in the such study, which means women are experiencing mental health condition and they are either not picked up early, or even if they are picked up, it is not clear as to whether they are able to access help and receive the care that they require. And in conclusion, colleagues, it is important to note that PTSD is highly prevalent among pregnant women attending a community-based antenatal clinic here in the district, and that PTSD was associated with alcohol use in pregnancy. Therefore, it is important that we increase the capacity of antenatal nursing staff through additional training, and improved human resources is recommended. In particular, the addition of registered counselors and social workers to antenatal clinics and midwifery units would be beneficial. Thanks, colleagues.
Let's give another round of applause for Dr. Makata. Thank you for your patience, guys, and apologies that our program did run a bit later than we expected it. It's, again, me, Regenerate Matambo, from the district of Johannesburg District Health. I think that's right. Have a good day. Now I will hand over to Ms. T. Ramatlo to come and close for us. Thank you.
The final good afternoon, colleagues. I hope this day was as productive for you as it was for me. Thank you for being a great audience. That t-shirt is very nice. I can see they are lifting and assessing. At least we know they'll diagnose it correctly. Colleagues, I know there's an element of discussion, but due to time, I would just like to just summarize the day and give maybe a message to the colleagues. I still hope, kusasemnandi ukubalana. Is it still nice to be here? Aye, guys, abgaya le na itshwana le. La itsa ke abga skin. Colleagues, I would like to thank Mr. Pitsi in absentia for his opening remarks when he reminded us that indeed nurses and midwives, we are the backbone of the healthcare system. And thank him also for the MEC speech that actually summarized the issue of communication with our patients and with each other. That was also supported by SENC when they spoke of handover. Handover has fallen off, colleagues. 10A, we don't call our patient by names. Let us go back and not improve, actually, let's improve on handover, because we can see that you can be charged with a misconduct with regards to poor handover practices. A mention also that was made through the MEC speech was the issue of night shift handover and night shift conduct. When we work night duty, we know that at 3, it will definitely have ptosis. But can we please continue doing our work with respect? And then the summary of that was that we must provide calm, consistent, and compassionate care. Mam Zondi, thank you for your presentation. The 4 indicators we noted. We noted couple-year protection, immunization under 1-year coverage, measles and rubella second dose coverage, and the cervical cancer screening. Colleagues, I know we are doing the work. We are genuinely doing the work. They must just get us equipment. So we will continue doing the work and we will improve. To Ms. Mashau, thank you for your presentation. And we do acknowledge the apology that was made, particularly to Westland. And thank you, Westland, for always submitting first. Mem Mutshekwa, your Saving Mothers report really made us see the work that we do and made us see where we lack. And indeed, we promise that we will improve ourselves. To the panel, I would like to thank the DTG for her presence and her participation. I would like to thank Mr. Serungwa for his participation. Mem Esh and Dr. Mulapo from SANC in absentia, I would like to thank them. I would like to thank Mem Meki from GCON also for sharing with us. Colleagues, master's degrees, they heard you. If you want to go teach, let's hope DTG will increase the money, then we can go teach. And I would like to thank my esteemed colleague, Dr. Tukisi, for facilitating with me. That was really great indeed. Dr. Molefe, we will indeed prioritize PrEP for pregnant women, and we will improve record keeping. Mem Chauke, the midwives' experiences in Limpopo are not far different from what we experience in Gauteng, though there would be elements here and there that are different because of geography. Other than that, I heard the nurses allude to everything that you presented. They experienced that. Dr. Ponyan, respectful maternity care is the core of our business. I think by the time that we all leave this conference, we would agree that respectful maternity care is our license to care for women. And actually now we're no longer saying women and we say birthing persons, because now we must be gender fluid. And yes, freedom from harm is important, and we must always remember that experience of care is subjective. If the woman said you made her feel in a particular manner, you made her feel in a particular manner, accept it, apologize, let's move on. Dr. Mahata, thank you for your presentation. It links with what the other presenters have been speaking about, issues of mental health care, screening, and identifying mental health conditions. Indeed, of concern it is that once there is identification, there's poor referral or intervention for antenatal women. Colleagues, that was in a nutshell our day. I would like to thank my fellow facilitators. I am proud to say, as a young manager, we have young leaders, we've seen them. Ms. Ramalopi, Mr. Mehali, and Ms. Matambo, I thank you for holding with me the baton. Above all, colleagues, Bansainela, ba task team askis. The task team, both district and provincial, I would like to thank you for the hard work that you did. First day hiccups, but we know teething problems are always there. And I would like to thank our sponsors, the media team, our tech team, our slideshow operator. We thank you for all the hard work. We thank the catering team as well. Colleagues, I hope by now you are not bothered by my voice. My voice is very international, as some of you might know. Anyway, colleagues, in a nutshell, that is our day. I really genuinely and humbly like to thank you and show gratitude to you for your participation. You were indeed a great audience, and I thank you. Before we close, I need someone to sing this song for us. Where do you brighten? The corner. In reflection, this one, it's a good introspection, alone, no teamwork. You go back home, you ask yourself, within the principles of RMC, respectful maternity care, where are you? Take stock. Ne? I know that Mem said, Kolratong, they see 14, 20 patients. I agree. And it's painful, it's exhausting. But take stock to say, where am I placing myself within the principles of respectful maternity care? In conclusion, may we please sing Brighten the Corner where you are, and please continue to make a difference. Thank you. And I'd like to thank myself for the work that I did. Thank you.